Good morning, everyone. It's 10 a.m. Central Time and 11 a.m. Eastern Time. We're going to begin the May 12th meeting of the emergency meeting of the ACIP. I want to welcome everyone here. Thank you again for all the time that you're dedicating to this and for attending these meetings. I'm going to turn it over to Dr. Cohn for comments at this time.
Thank you, Dr. Romero. And I also want to extend our welcome to this ACIP emergency meeting to address the recently authorized new age group for the Pfizer mRNA COVID vaccine. We'll do a couple of introductory slides. Copies of the slides being presented at today's meeting are available on the ACIP website. And additionally, they're available through a share file link for the ACIP voting liaison and ex officio members. The slides may come down temporarily after the ACIP meeting and will be put up once they are 508 compliant. And there may be some slides that are not yet available for this afternoon's portion of the meeting, but they will be made available in the next couple of hours. I ask that all ACIP members mute their lines until you're called on for discussion. When Dr. Romero opens the meeting, please virtually raise your hand. First, Dr. Romero will take questions from the ACIP members and then from an ex officio and liaison members. Please disable your video until a potential vote, and ACIP members will turn on their video during a vote. Next slide. The Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period this afternoon. It will occur at approximately 2 p.m. Eastern Standard Time. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2021-0049. Information on the written public comment process, as well as information about how to make a written comment, can be found on the ACIP website. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that may enhance a member's expertise, CDC has issued limited conflict of interest waivers. Members who conduct clinical vaccine trials or serve on data safety monitoring boards may present to the committee, but these members are prohibited from participating on committee votes on issues related to those vaccines or to the companies for which those vaccines, other vaccines that same company makes. During roll call, the ACIP members will indicate if they have and disclose any conflicts of interest, and they'll do so again at the beginning of the vote. Before I hand it over to the chair to start roll call, next slide, I want to remind everybody that the ACIP is accepting applications for new membership starting on the term of July 1st, 2022. And we are looking for applicants from all fields of public health, internal medicine, OBGYN, pediatrics, and infectious disease expertise, as well as consumer representatives. We ask that all applications be submitted by July 1st, 2021 for a term starting July 1st, 2022. There is information about how to apply to be an ACIP member, and the application is available on the ACIP website. Next, it is my pleasure to introduce Dr. Sam Posner, who is currently the acting director of the National Center for Immunization and Respiratory Diseases, to say a few words to members of the committee and to the public.
Thank you very much, Dr. Cohn, and welcome to the emergency ACIP meeting. I want to thank you all for your time and commitment to ACIP. Before we get started, I wanted to take just a few minutes to update you on some leadership transitions within the National Center for Immunization and Respiratory Diseases. As many of you may already be aware, Dr. Messonnier has resigned from her position as Director of NCIRD effective this coming Friday. I will continue to serve as the acting director for NCIRD until a permanent replacement has been hired. As we've seen over the past year, the ACIP plays an essential role in our collective efforts to protect people from vaccine-preventable diseases. I want to thank you for your commitment to both the scientific rigor and ethical and equitable health outcomes. Service on this committee has been extremely demanding during the COVID-19 pandemic, and we appreciate your stewardship of this historic and influential group. I'd like to take a few minutes to recognize Dr. Messonnier and her amazing contributions to public health. Many of us in the formal and informal ACIP community have worked with Nancy for many years and are familiar with the outstanding contributions to public health that she has made during her CDC career. Many of you and your organizations have worked with Nancy on some of these accomplishments. Nancy began her career at CDC over 25 years ago as an EIS officer and became involved with emergency response early on as one of the staff involved in the 2001 intentional anthrax release. She's built extensive experience in prevention and control of bacterial meningitis and played a pivotal role in the successful public-private partnership to develop and implement a low-cost vaccine to prevent epidemic meningococcal meningitis in Africa. As director of NCIRD, Nancy oversaw strategies to counter threats like seasonal and pandemic influenza and has led the center through the recent measles resurgence and the emergence and cyclical outbreaks of acute flaccid myelitis. Since the beginning of the pandemic, in collaboration with all of you and our partners across public health and the state, tribal, and local and territorial governments, Nancy has led teams to achieve incredible things, including deploying multiple vaccines in under 1 year and building the information infrastructure to provide real-time data for vaccination coverage and vaccine safety data. Nancy is going to continue her work in public health and will continue become the executive director of pandemics and health systems for the Skoll Foundation. I know that she has valued the singular purpose and role of ACIP and the varied perspectives that all of the members and the public brings to CDC and to our national immunization program. On behalf of the entire center leadership team, I want to thank the entire ACIP for your continued service, and thanks especially to Dr. Cohn and Dr. Romero for giving me a few minutes to provide this update.
Thank you, Dr. Posner. Dr. Romero, I'm going to turn it back over to you to begin roll call.
Thank you, Dr. Cohn. Let me begin by saying that on my behalf and on behalf, I'm sure, of all of the members of the ACIP, we are greatly going to miss Nancy, Dr. Messonnier. She's been a role model for us, and we appreciate all of her hard work during her tenure at the CDC. So with that, let me begin with roll call. I'll start with myself. Remember to state your affiliation and any conflicts of interest. So Jose Romero, I am the Secretary of Health and Director of the Department of Health in Arkansas, Professor of Pediatrics and Pediatric Infectious Diseases at the University of Arkansas for Medical Sciences, no conflicts. Dr. Alt. Dr. Alt, I'll come back to that. Ms. Bata.
Good morning, Lynn Bata, Immunization Clinical Consultant at the Minnesota Department of Health, and I have no conflicts.
Good morning, welcome. Dr. Bell.
Dr. Bell Dr. Bell may not be available for the beginning portion of the meeting, but she'll be on shortly.
Thank you, Dr. Cohn. Dr. Bernstein.
Good morning. I'm Hank Bernstein. I'm a professor of pediatrics at Zucker School of Medicine at Hofstra Northwell. I have no conflicts.
Welcome. Dr. Chen.
Wilbur Chen, adult infectious disease physician at the Center for Vaccine Development and Global Health in the University of Maryland School of Medicine. I have no conflicts.
Good morning. Dr. Daly.
Good morning. Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado. I'm also an associate professor at the University of Colorado School of Medicine. I have no conflicts.
Welcome. Dr. Fry.
Good morning, Sharon Fry. I'm professor of internal medicine at St. Louis University and the clinical director for the St. Louis University Center for Vaccine Development. I do have two conflicts of interest. I am the site PI at St. Louis University for the Moderna and the Janssen SARS-CoV-2 vaccine trials in adults.
Thank you. Good morning.
Thank you.
Dr. Cotton.
Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor of medicine at Harvard Medical School. I have no conflicts of interest for this topic.
Welcome. Dr. Lee.
Morning, Grace Lee, professor of pediatrics, Stanford University School of Medicine, associate chief medical officer, Stanford Children's Health. I have no conflicts.
Welcome. Dr. Long.
Good morning, I'm Sarah Long. I'm professor of pediatrics in pediatric infectious diseases at Drexel University College of Medicine in Philadelphia. I have no conflict.
Good morning. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Welcome. Dr. Paling.
Good morning. This is Kathy Paling. I'm professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine. I have no conflicts.
Good morning. Dr. Sanchez.
Morning. This is Pablo Sanchez. I'm a professor of pediatrics and neonatology and pediatric infectious diseases at Nationwide Children's Hospital and The Ohio State University in Columbus, Ohio, and I have no conflicts. Thank you, Jose.
Thank you and welcome. Dr. Talbot.
Good morning. This is Kip Talbot at Vanderbilt University Medical Center, where I'm an associate professor in adult infectious diseases.
Good morning. Welcome. Let me circle around and see if Dr. Alt has joined the group.
This is Kevin Alt, and I'm here. Can you hear me?
Yes, we can, sir.
I am calling in by phone because I'm trying to finish up clinic, and I'm a practicing obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas. And no conflict.
Thank you. Good morning. Thank you. Good morning, and thank you for your dedication. We'll wait until Dr. Bell announces herself later. Very good. So that ends the roll call for the ACIP members. I'm now going to go on to the ex officio representatives, and I will state your organization. Centers for Disease Control and Prevention.
Good morning. This is Melinda Wharton from the National Center for Immunization and Respiratory Diseases at CDC.
Good morning. Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance representing the Centers for Medicare and Medicaid Services.
Welcome. Good morning. Food and Drug Administration.
Good morning. Dorn Fink for U.S. Food and Drug Administration, Office of Excellence.
Good morning. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, Health Resources and Services Administration.
Welcome. Indian Health Service.
Good morning. Captain Thomas Weiser for Indian Health Service.
Good morning. National Institutes of Health.
Good morning. John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Welcome. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. David Kim with the Office of Infectious Disease and HIV/AIDS Policy, Office of the Assistant Secretary for Health.
Good morning. We're moving on now to the liaison representatives. Again, I will call your organization and answer if present. American Academy of Family Physicians.
Pamela Rockwell, AAFP, present.
Good morning. American Academy of Pediatrics, AAP.
Good morning. Bonnie Maldonado, Professor of Global Health and Infectious Diseases and Chair of the Committee on Infectious Diseases for the AAP.
Good morning. American Academy of Pediatrics, Red Book.
David Kimberlin, University of Alabama at Birmingham. I'm editor of the AAP Red Book.
Good morning, welcome. American Academy of Physician Assistants.
Good morning, Marie-Michelle Léger, representing the American Academy of PAs, Director of Clinical Affairs.
Welcome. American College Health Association.
Good morning, Sharon McMullen from Cornell University, and also my co-liaison representative, Dr. Tavi Chai from University of North Carolina at Chapel Hill, present.
Welcome to you both. American College of Nurse Midwives.
Carol Hayes, present.
Good morning. American College of Obstetricians and Gynecologists.
I am Barbara Fisher. I'm a maternal fetal medicine physician at Northwest Perinatal Center in Portland, Oregon. I represent today the American College of Obstetricians and Gynecologists, No Conflicts.
And Lisa Ip, also representing ACOG. I'm a professor of pediatrics at Law Cornell Medicine and an adolescent medicine specialist. No conflicts.
Thank you. Sorry to cut you off.
Not at all.
American College of Physicians.
Good morning, Dr. Jason Goldman, practicing general internal medicine, affiliate assistant professor at Florida Atlantic University. Pleasure to be here representing the American College of Physicians.
Welcome. American Geriatric Society.
Ken Schmader here for AGS.
Good morning. America's Health Insurance Plans.
Yeah, this is Bob Gluckman. I'm an internist, chief medical officer for Providence Health Plans. I have minor stock holdings in Abbott, AbbVie, Bristol Myers Squibb, Procter & Gamble, and Walgreens.
Thank you. Good morning. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing the American Immunization Registry Association.
Thank you. Good morning. American Medical Association.
Good morning. I'm Dr. Sandra Freihofer, general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Good morning and welcome. American Nurses Association.
Good morning, Chad Riddle, representing the ANA.
Welcome. American Osteopathic Association.
Good morning, Stan Grogg, Professor Emeritus, Oklahoma State University, representing the American Osteopathic Association. Thank you.
Welcome. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean of the Loma Linda University School of Pharmacy and Professor of Preventative Medicine in the School of Medicine at Loma Linda, representing the American Pharmacists Association.
Thank you. Good morning. Welcome. Association of Immunization Managers.
Hi, everyone. Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Welcome. Association for Prevention, Teaching, and Research.
Dr. Paul McKinney, Professor of School of Public Health and Information Sciences, University of Louisville.
Good morning. Association of State and Territorial Health Officers.
Good morning, everyone. This is Nirav Shah. I'm the Director of the State of Maine Center for Disease Control and Prevention and the President of ASTA.
Welcome and thank you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing Bio.
Thank you. Good morning. Council of State and Territorial Epidemiologists.
Good morning. This is Susan Lett, representing the Council of State and Territorial Epidemiologists. Can everybody hear me?
We can hear you. Thank you. Welcome.
Great. Thank you.
Canadian National Advisory Committee on Immunization.
Hi, Carolyn Quash, Matthew Chair. Good morning.
Good morning. Infectious Diseases Society of America.
Good morning, Dr. Romero. This is Jeff Duchin, Health Officer for Public Health, Seattle and King County, Washington, and Professor in Medicine, Division of Infectious Diseases at the University of Washington.
Good morning and welcome. International Society for Travel Medicine.
Good morning, Elizabeth Barnett here for ISTM.
Thank you. Welcome. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing the HO President.
Welcome. Good morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield from Children's Minnesota, representing NAPNAP.
Welcome. Good morning. National Foundation for Infectious Diseases.
This is Dr. Bill Schaffner,
Professor of Infectious Diseases at Vanderbilt, representing the NFID. Good morning.
Welcome. Good morning. National Medical Association.
Dr. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in Los Angeles, representing the NMA. Good morning.
Good morning and welcome, sir.
Thank you.
Pediatric Infectious Diseases Society.
Good morning, Sean O'Leary, representing the Pediatric Infectious Diseases Society.
Good morning, welcome. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Thank you. Good morning. Society for Adolescent Health and Medicine.
Hi, it's Dr. Amy Middleman, representing SAM. Good morning, everyone.
Hello and good morning. Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care.
Thank you. Thank you. That ends our roll call. Did I, as I'm known to do occasionally, omit anybody from the roll call? Hearing none, then I'm going to ask Dr. Doran Fink to please make a few comments before we go on to the presentations. Dr. Fink, are you ready?
Yes, thank you, Dr. Romero. So the purpose of today's ACIP meeting is to consider the data that supported FDA authorization of the Pfizer-BioNTech COVID-19 vaccine for use in adolescents 12 through 15 years of age. These data were generated from a randomized placebo-controlled study involving over 2,200 participants, over 1,100 of which received the Pfizer-BioNTech COVID-19 vaccine, and 660 of which approximately had at least 2 months of follow-up after completion of the vaccination series. The evidence for vaccine effectiveness in this age group came from two sources of data. First, immunobridging analyses showing that neutralizing antibody responses elicited by the vaccine in adolescents 12 through 15 years of age were non-inferior to those elicited by the vaccine in adults 18 through 25 years of age. Additionally, the study evaluated protection against COVID-19 of any severity for the vaccine versus the placebo control. And there were 0 cases of COVID-19 in vaccine recipients starting from 7 days after completion of the vaccination series. The safety of the vaccine was evaluated in all of the study participants and compared to the placebo control. It was also compared to the safety profile of the vaccine in study participants 18 through 25 years of age in the population that supported the original emergency use authorization of the vaccine back in December of 2020. Additionally, FDA evaluated longer-term safety data from all adult participants in the clinical trial who were 18 through 55 years of age and included in the emergency use authorization safety population. The safety evaluation did not raise any safety concerns for use of the vaccine in individuals 12 through 15 years of age beyond reactogenicity, events that had previously been described with older age groups. Thank you very much.
Thank you, Dr. Fink. Dr. Cohn, do you have any other comments, or can we proceed with the presentation?
We can proceed with the presentations.
Thank you very much. So we'll proceed then with coronavirus disease 2019 COVID-19 vaccines with an introduction provided by Dr. Kit Talbot. Dr. Talbot, would you go forward, please?
Yes, happy to. Good morning. Do I have control of the slides, or do I just say next? Oh, it's magic. Okay.
You just say next.
The COVID work group activities update for May 2021 continues. The COVID work group continues to meet weekly. The topics covered have included the clinical trial data for the Pfizer-BioNTech COVID-19 vaccine for adolescents, the grade and ETR for the Pfizer-BioNTech COVID-19 vaccine for adolescents, clinical considerations for this age group, and safety updates. The big update is on May 10th, the Food and Drug Administration issued an emergency use authorization for use of the Pfizer-BioNTech COVID-19 vaccine for the prevention of coronavirus disease 2019 for individuals 12 to 15 years of age. Next. Today's agenda is busy. It includes safety, immunogenicity, and efficacy of the vaccine in persons aged 12 to 15 years by Pfizer. We will do a grade of the Pfizer-BioNTech COVID-19 vaccine. We'll do the evidence to recommendation framework for the vaccine in adolescents. We'll discuss clinical considerations of using the adolescent vaccine. We will have public comments, discussion, and a vote for using the Pfizer-BioNTech COVID-19 vaccine for 12 to 15-year-olds. Next. This will be followed by an update on thrombosis with thrombocytopenia syndrome, TTS, following the Janssen COVID-19 vaccine. We'll have an update from the VAS committee by Dr. Grace Lee. We will have an update on the COVID-19 vaccine effectiveness studies and an update on the emerging SARS-CoV-2 variant and the implications for our vaccine. Next. This has truly taken a village. You can see the ACIP members that serve on the work group, the ex officio members, the CDC lead, and all of the liaisons and consultants who've put extra time and effort into this. Next slide. It has taken a large group from the CDC to make all of this happen, and we'd like to say thank you for that. Next slide. And this is just a thank you slide, but I would like to take a moment to talk about the children in the U.S. They have been part of this pandemic, whether they have experienced infection, lost loved ones, lost parents, have been out of school, have not had their extracurriculars. And for many kids, without school also means they're without a safe place and food. And so I'm happy that we're finally beginning to talk about the children and returning their lives to normal. Thank you very much.
Thank you very much, Dr. Talbot. We will proceed with the presentation by Dr. John Perez on safety, immunogenicity, and efficacy of BNT162B2 in persons aged 12 to 15 years. Dr. Perez?
Good morning. Could you hear me, please?
We can. Thank you, sir.
Thank you. Good morning. Today, I have the honor of presenting the safety, immunogenicity, and efficacy of our COVID-19 vaccine in subjects 12 to 15 years of age. Next slide, please. Our pivotal study was one for adults. However, once we were able to establish that the vaccine was tolerated in adults, we amended the protocol to include 16 and 17 years of age in the study. Once it was clear that that group could tolerate the vaccine, we amended the study to include 12 to 15-year-olds. And we did that at the same dose and schedule as adults without further dose binding. The reason we did this was to generate data to understand whether people 12 to 15 years of age could be included in pandemic COVID-19 immunization programs. So today I'm going to present the data from dose 1 to 1 month post-dose 2 in our 12 to 15 and 16 to 25-year-olds, and from dose 1 to the data cutoff point on March 13th, 2021 in our 12 to 15-year-olds. And please note that the data from subjects 16 to 25 years of age were used for the safety comparisons and for immunobridging purposes. Next slide, please. So this is the schema for the study. 2 doses of vaccine were given 21 days apart, and then active surveillance for COVID was undertaken. Anyone who had potential COVID-19 symptoms triggered a telehealth or an in-person visit, and a nasal swab was performed. Reactogenicity was measured 7 days after each dose of vaccine using an electronic diary. This was done in a subset of individuals for 16 and above, but for all of the 12 to 15-year-olds. We measured non-serious adverse events through 1 month post-dose 2, serious adverse events through 6 months post-dose 2, and deaths throughout the study. Overall, we had 2,260 12 to 15-year-olds. We had 1,097 16 to 25-year-olds. And as a reminder, subjects with a history of symptomatic COVID-19 or MIS-C were excluded. Next slide, please. Let's look at the demography. So in this slide, you see in blue the vaccine group, the 2 age cohorts, and in gray the placebo. Along the left-hand side, you see the demographic variables we measured. And what you can see as you compare a vaccine and placebo is that we were well balanced with these demographic variables. Roughly half the group was female, about 86% were white, 5% were Black or African American, 6% were Asian, and about 12% were Latino. All of the subjects in the 12 to 15-year-old cohort were from the United States. In the 16 to 25-year-olds, about 71% were from the United States, and the rest were from a smattering of other countries included in the trial. Next slide, please. Let's look at reactogenicity. Next slide. Here what you see are local reactions by maximum severity within 7 days after each dose in the 2 age cohorts. In the top row, you see dose 1, and the bottom row, dose 2. On the y-axis, we're reporting the percent frequency for redness, swelling, and pain at the injection site. Severity is measured from mild to grade 4. And then within each reactogenicity, we're comparing vaccine to placebo for each of the 2 age cohorts. So the first thing you see is that pain at the injection site was the most frequent local reaction reported in the study, with 86.2% in the 12 to 15-year-olds for the first dose, and decreasing a little bit to 78.9% with the second dose. The other thing you'll see is that most of the reactions that were reported were mild to moderate in severity. For redness and swelling, we see about 5 to 7% of reporting redness and swelling for dose 1 and for dose 2. Next slide, please. We turn our attention to systemic events by maximum severity within 7 days after dose 1. So this is just data for dose 1. In the top row, we see the vaccine group, and in the bottom row, the placebo group. And the severity scales are the same. So let me draw your attention all the way on the right to fever. We see that 10.1% in the 12 to 15-year-old age group reported a fever, compared to 7.3% in the 16 to 25-year-olds. We also see that fatigue, headache, and chills were also frequently reported in this age cohort. Vomiting and diarrhea was reported at similar frequencies to placebo, and muscle pain and joint pain were also reported, but the frequency was slightly higher in the 16 to 25-year-olds as compared to the 12 to 15-year-olds. Next slide, please. Now we're presenting the same information for dose 2. And if I direct your attention to fever on the left, what you see is that the frequency of fever has increased from 10% with the first dose to 19.6% with the second dose. And similarly, fatigue, headache, and chills have also increased with the second dose. For vomiting and diarrhea, there was really no increase, similar to vaccine. And for muscle and joint pain, we see that they also increased with the second dose, but were higher in the 16 to 25-year-olds as compared to the 12 to 15-year-olds. I would point out that this is precisely the same pattern that we've seen in individuals 16 years of age and above in the entire study. Please. Next slide, please. If we look at local reactions, what we saw was it was predominantly pain at the injection site, and it was more prominent with the first dose. And from a severity perspective, they were mostly mild to moderate. For systemic events, we saw predominantly fatigue, headache, chills, muscle pain, as well as fever and joint pain. And they were more prominent after the second dose, but again, mostly mild to moderate in severity. Next slide, please. Now let's turn our attention to adverse events reported in the study. Next slide. So here what you see is overall adverse events from dose 1 to 1 month post-dose 2 in the 2 age cohorts. In the top panel, we see the 12 to 15-year-olds, and in the bottom panel, we see the 16 to 25-year-olds. So looking at the 12 to 15-year-olds in frequency, on the y-axis from 0 to 100%, we see that 6% in the vaccine group reported adverse events compared to 5.9% in the placebo group. In the 16 to 25-year-olds, we see that 10.8% reported adverse events compared to 8% in the placebo group. If we move along the x-axis, we see that for related adverse events in both groups, there was slightly more related adverse events reported in the vaccine as compared to the placebo. And then if we look at SAEs, related SAEs, and withdrawals to the AEs, we see similar rates between vaccine and placebo and low rates for all of these events. In terms of withdrawal due to AEs, there was one subject in the vaccine group in 12 to 15-year-olds who had no past medical history and developed a fever the day after vaccination of 104.7. The fever abated and resolved the next day after vaccination without sequelae. The patient remains in the study and is being followed for safety. No deaths have been reported in the study. Next slide, please. Now, if we continue to follow these subjects from dose 1 to the data cutoff date of 13th of March, what we find is the same pattern we saw through 1 month post-dose 2. In the vaccine group, 6.4% reported adverse events compared to 6.3% in the placebo group. There were slightly more related adverse events in the vaccine group compared to the placebo. And again, we continue to have low rates of serious adverse events, no related serious adverse events, and no additional withdrawals, and no deaths. Next slide, please. So let's dig a little deeper. Now we're reporting adverse events by greater than or equal to 1% by system, organ, class, or SOC for the 12 to 15-year-olds, 1 month post-dose 2. So if we look at overall, there's that 6% in the vaccine group compared to the 5.9% in the placebo group. And what we see is that the difference between vaccine and placebo is driven by 3 system organ class classifications: general disorders, gastrointestinal disorders, and nervous system disorders. And these are the system organ class classification where reactogenicity adverse events would be reported. So for example, in the general disorders SOC, that is where you would see injection site reactions reported and systemic reactions such as fever and fatigue reported, and that's exactly what we observed in that SOC. In the gastrointestinal disorders, that's where nausea and diarrhea would be reported, and in the nervous system disorders, that's where headache is being reported. Next slide, please. Now, if we look at adverse events greater than 1% by system organ class in the comparison group, the 16 to 25-year-olds, we see the exact same pattern. So there was 10.8% who reported an adverse event in the vaccine group compared to 8% in the placebo, and that difference is being driven by similar system organ classes, reactogenicity event being reported as adverse events. The new system organ class here is the musculoskeletal and connective tissue disorders, SOC, which is where myalgias or arthralgias would be reported. So the same pattern between 12 to 15 and 16 to 25-year-olds. Next slide, please. And then if we continue to follow individuals to the data cutoff date of the 13th of March, again, we're not picking up much more than what we've seen 1 month after the second dose. Again, most of the adverse events that are being reported are reported in the general disorders, gastrointestinal and nervous system disorders, and the differences are being driven by injection site reactions and some systemic reactions. So we're not picking up additional types of adverse events with further follow-up. Next slide, please. So one adverse event that was associated with the vaccine was lymphadenopathy. Overall, there were 9 cases of 0.8% in the vaccine group and 2 cases in the placebo group of 0.2%. If we just focus on those that were related to vaccination by the investigator, we find 7 cases or 0.6% compared to the placebo group of 0.1%. These were predominantly left axillary and left cervical lymphadenopathy. I will remind the group that we vaccinated in the non-dominant arm, which in most individuals would be the left arm. Onset was between 2 and 10 days after vaccination. The duration was 1 to 10 days where it was reported. And then to compare in adults 16 to 55 years of age, 52 participants of 0.4% in the vaccine group compared to 2 participants in the placebo group had lymphadenopathy events reported up to the unblinding date and assessed by the investigators related to study intervention. The majority of these events occurred in the arm of the neck region. They were reported within 2 to 4 days after vaccination, typically after dose 2, and typically resolving within approximately 1 week of starting. Next slide, please. Now let's turn our attention to serious adverse events by system, organ, class, and preferred term from dose 1 to the data cutoff date of the 13th of March. And what you can see is overall there was a low rate of serious adverse events reported. In the vaccine group, there were 5 events reported, giving a rate of 0.4%, and in the placebo group, there were 2 events reported, giving a rate of 0.1%. Now, one thing to notice about this data is that many of the adverse events were reported by single individuals. So, for example, abdominal pain, constipation, and neuralgia was reported by 1 individual. This individual presented with abdominal pain, had multiple physical examinations and laboratory evaluations for these complaints, but ultimately a diagnosis of functional abdominal pain was made. In the psychiatric disorders, we see depression, anxiety, and suicidal ideation. All of these individuals had a history of depression and or anxiety that was active at the time of vaccination. For 2 of the depressions and the suicidal ideation case, these individuals had been started on a selective serotonin reuptake inhibitor 1 to 2 months before vaccination. And for the subject with depression and anxiety, this individual had a history of depression, being treated with SSRIs, and an extensive history of multiple anxiety disorders. Next slide, please. And as a reminder, there were no deaths reported in the study. Next slide, please. So now let's talk about efficacy and immunogenicity. Next slide. So here is the follow-up time after dose 2 in the 12 to 15-year-olds. So in the left-hand column, you see total exposure from dose 2 to the cutoff date. And we divided that into less than 1 month, 1 to 2 months, 2 to 3 months, and greater than 3 months. And then in the next column is the vaccine, in the next placebo, and then finally the total. And what you can see is that 54.1% of the vaccine group had between 2 and 3 months of follow-up at the time of our analysis, with an additional 4.2% having greater than 3 months after the second dose at the time of this analysis. Overall, 98.3% of the subjects had at least 1 month of follow-up time in the study. Next slide, please. So now let's look at the immune response. So here what you see is the geometric mean titers of a SARS-CoV-2 neutralization assay, the NT50, in subjects from the 2 age cohorts. So on the y-axis, you see on a log scale from 1 to 10,000, the geometric mean titers of the neutralization assay. And on the x-axis, you see day 1 before vaccination and then 1 month post-dose 2 as the next assessment. In this particular assay, values of 20 and above would be measurable and valid assay results. So what you can see is before vaccination and in the placebo group at all evaluations, there was essentially no measurable neutralization result. However, 1 month after the second dose, you can see in the 12 to 15-year-olds, the geometric mean titer increased to 1283, and in the 16 to 25-year-olds, that GMT increased to 730.8. So the vaccine was able to generate in both groups potent neutralization responses. Next slide, please. And here is the non-inferiority analysis between the 2 age cohorts. This was the primary endpoint to evaluate immunobridging between the 2 age cohorts. So what you see here is the neutralization titer in the 12 to 15-year-olds 1 month after the second dose. And you can see that that neutralization titer was 1239.5. This analysis only included people who had no signs of infection prior to or during the study. So in that group, 1239.5 was the GMT. That compared to a GMT of 705.1 in the 16 to 25-year-olds. If you were to divide 1239 by 705, you would get a geometric mean ratio of 1.76. You generate a 95% confidence interval around that. You see it goes from 1.47 to 2.10. Non-inferiority is declared if the lower bound of the 95% confidence interval is greater than 0.67. 0.67 is the natural log of 1.5, which is our non-inferiority margin used for this analysis. So what you can see is that 1.47 is much greater than 0.67, and hence we met our predefined non-inferiority margin in this study. I would also like to point out that because the lower limit of the 95% confidence interval of the GMR is greater than 1, that indicates a statistically greater response in the 12 to 15 as compared to the 16 to 25-year-olds. Next slide, please. Here, what we're looking at is efficacy. So we have the opportunity to look at efficacy from a descriptive perspective. So we're looking at subjects without evidence of infection prior to 7 days after the second dose. So what you can see is that in the vaccine group, there were no cases of COVID-19 in individuals vaccinated with our vaccine. And in the placebo group, there were 16 individuals who developed COVID-19. That calculates out to a vaccine efficacy of 100%, with the 95% confidence interval going from 75.3 to 100%. In this study, there were no severe COVID-19 cases. Next slide, please. Now, if we look at individuals with or without evidence of infection prior to 7 days after dose 2, what we find is we pick up an additional 2 cases in the placebo group. So now we have 18 cases in the placebo group, 0 cases in the vaccine group. Again, this calculates out to a vaccine efficacy of 100% with a tighter 95% confidence interval. There were no severe COVID-19 cases in this analysis. Next slide, please. So overall, from a safety perspective, we found that reactogenicity was well tolerated in subjects 12 to 15 years of age and showed a very similar pattern to what was seen in the 16 to 25-year-olds, and I would say in the rest of the study. Pain at the injection site, fatigue, headache, chills, joint pain, muscle pain were the most predominant, as well as fever. And there were increased systemic events after dose 2, and were similar to what we saw in the 16 to 25-year-olds. Adverse events overall were relatively few. The highest incidence was in the system organ class of general disorders and administrative site conditions reflecting local and systemic reactogenicity events. Lymphadenopathy was identified as related to vaccination, and there were no related SAEs and no deaths were reported in the study. Next slide, please. In terms of immunogenicity and efficacy, we saw that the immune response to the Pfizer-BioNTech COVID-19 vaccine, in terms of our SARS-CoV-2 50% neutralization titers in adolescents, was non-inferior to and in fact exceeded the immune response in young adults 16 to 25 years of age, thus providing immunobridging between adolescents in this pivotal study. In the adolescent group, efficacy analysis based on the cases reported from at least 7 days after dose 2 through the data cutoff date, we observed a vaccine efficacy of 100% for individuals without evidence of prior SARS-CoV-2 infection and 100% in those with or without evidence of prior SARS-CoV-2 infection before their vaccination regimen. There were no severe cases reported in the 12 to 15-year-old age cohort as of the data cutoff, and overall, we believe that these immunogenicity and efficacy data strongly support the vaccine use in adolescents 12 to 15 years of age. And that concludes my presentation. Thank you very much for your attention.
Thank you very much for that clear and thorough presentation. We will open it up now to the voting members of the ACIP for their questions, if there are any. I Dr. Paling, please go forward.
Thank you, Dr. Perez, for this very helpful presentation. Would you please remind us about the placebo and what the placebo that was used in this trial? And then, so let me start there.
The placebo was saline.
Okay, wonderful. And then have you had a chance to look at the results for both safety and immunogenicity by race and ethnicity? And would be interested in hearing about that, if you have.
No, we have not performed that analysis by race or ethnicity.
Thank you. Dr. Long?
Yes, it's a question about psychiatric disorders to try to understand whether this has something to do with a vaccine administration or potentially a reactogenicity of vaccine that led to exacerbations. So the first question is, psychiatric disorders that are active that children receive therapy, chemotherapy, are pretty significant. So the question is, what percent or how many cases in those who didn't report adverse events was there an active psychiatric diagnosis, both in the vaccine group and in the placebo group?
So overall, approximately 25% in the vaccine and placebo group had an active psychiatric diagnosis when they came into the trial.
Wow. Did that mean they were receiving some active drug for it, or just anxiety? I could see get you up pretty high, but they were receiving some therapy for that.
What that meant was that they had a medical history of a psychiatric diagnosis upon entry into the study. Some of them were being treated for their illnesses, some were not. The most common psychiatric disorder was attention deficit disorder.
So you would think that there would be equal opportunity if this was not vaccine associated for both the vaccinated and the placebo group to have some exacerbation of their psychiatric disorder.
Correct.
And you mentioned that all of those who had this related to vaccine had a history, but now I'm impressed there were a lot of people with that history. So you did not have episodes. There was there one, or do I remembering that there were none? Was none in the placebo group?
Serious adverse events of a psychiatric diagnosis, there were none, correct.
And did you, do you know if those that had the psychiatric event did they all have reactogenicity from the vaccine? Did they have fatigue and pain and headache, for instance?
I don't have that information right in front of me. However, what I could tell you is that in terms of when these events were occurring relative to vaccine, in the case of the suicidal ideation, that occurred 40 days after the second dose. For the worsening depression, that occurred 2 days after the first dose. For the next depression case, that occurred 16 days after the first dose. And for the last case, it occurred 7 days after the dose. So of the SAEs that were reported, only one would have been occurring at the time that we would expect reactogenicity in a typical subject.
Thank you.
One other comment to make, the 25% psychiatric diagnosis, we also examined studies for other adolescent studies we've been doing over the past decade. And what we've been finding, especially in the meningococcal space, is about 20 to 25% of adolescents coming into our clinical trials have a psychiatric diagnosis. So these are studies that were done before 2020, obviously a key stressor in this country and globally.
Thank you very much. Dr. Lee.
Thank you. Dr. Perez, could you just please describe for us the case of neuralgia how that presented?
Certainly. So this was reported in an individual with a past medical history of attention deficit disorder who presented to the emergency room beginning the day after the second dose. At the emergency room, she was evaluated and reported other adverse events, including a GU abscess, gastritis, and contact dermatitis. She subsequently reported SAEs of abdominal pain and constipation. She had an extensive workup, including serial physical and laboratory examinations, and was diagnosed with functional abdominal pain. She was referred to psychology and physical therapy, after which symptoms were reported to be gradually improving.
Dr. Fink, this is Amanda. Would you want to make a comment about the FDA's review of some of these SEs?
Sure. So FDA did note the numerical imbalance in serious adverse events related to worsening of depression that was ongoing at the time of study enrollment. And we did evaluate narratives of these cases provided by the vaccine manufacturer. We also noted the proportion of the study population that entered the study with active psychiatric diagnoses, including most commonly ADHD, but also a fair number of subjects, approximately 4%, with a history of ongoing depression. We did also note that in 3 of these serious adverse events that were reported in vaccine recipients, a selective serotonin reuptake inhibitor medication had been initiated approximately 1 to 2 months prior to study enrollment, as had been previously mentioned in the Pfizer presentation that you just heard. These SSRIs do carry a boxed warning in the FDA package insert that they may worsen depression and cause suicidal ideation in adolescents specifically. And so we recognized these exposures to SSRIs as potentially contributing factors that offered a reasonable explanation for the events. At the other serious adverse event that occurred in a subject who was not taking a selective serotonin reuptake inhibitor, according to careful review of the narrative, revealed other psychosocial factors that were described by the participant that we felt constituted a reasonable explanation for the event. So taken together, although there was a small numerical imbalance with 0 cases in the placebo group, we did not see evidence to support a causative role of the vaccine in these events. Thank you.
Thank you. Dr. Lee wants to ask a follow-up question.
Thank you. I wanted to confirm, so the case of neuralgia ended up having a diagnosis of functional abdominal pain, so it was not peripheral extremities or face or anything else?
Correct.
Okay, thank you.
Thank you. Dr. Sanchez?
Yes, thank you, and thank you for that presentation. I have a question in terms of other vaccine administration. What was the, I'm sure that wasn't allowed, but what was your cutoff for other vaccines in this age group?
It's so for non-live vaccines, we generally have a 2-week window before investigational product and a licensed product, and for live vaccines, it's a month.
And are any plans to look at? Are you going to be looking at co-administration with other vaccines in this age group?
At the moment, there's no plans to do that, but for our COVID-19 program, plans change all the time.
Okay, thank you. But then I have another one. Were there any, so the vaccine efficacy was 100% 1 week after the second dose. I assume that there were no cases of COVID-19 after the first dose either?
There were 3 cases of COVID-19 after the first dose. Those occurred within the first few days after the first dose.
Okay. Thank you.
Dr. Stinchfield.
Yeah, thank you so much for this presentation. Patsy Stinchfield from NatNat. I noticed you mentioned that the vaccines were given in the non-dominant arm. Can you just clarify, was that for clinical trial consistency purposes, or is that a recommendation on administration?
That's for clinical trial purposes. It's standard practice we have when doing any clinical trial.
Dr. Long.
Yes, one last question about the psychiatric disorders. Maybe you showed us, but I was maybe focusing too narrowly. Did you show us psychiatric disorders reported in the 16 to 25-year-olds placebo control trial?
No, I did not. In the 16 to 25-year-olds, there was 1 SAE of depression in the vaccine group and 0 in the placebo group.
Thank you.
Dr. Paling.
Thank you. I wanted to ask, I did not see any reports of Bell's palsy, and I wanted to just ask about that. And did you see any blood clots of any type? Thank you.
There were no reports of Bell's palsy in the 12 to 15-year-old age group, and there were no blood clots of any sort reported in this age group.
Thank you. Are there any questions from the liaison members? Dr. Stinchfield, your hand is up. Is it a residual from your question?
Yes, it is. I'll take it down. Thanks.
Thank you. Anyone else? Dr. Paling.
One more. Were there any pregnancies during this trial?
Not in the 12 to 15-year-olds. There was 1 in the 16 to 25-year-olds.
Any other questions from the liaisons or the voting members? Seeing none, again, let me thank you, Dr. Perez, for your presentation and for your answers to the many questions that you fielded. Thank you very much.
Thank you.
We'll now go on to the presentation by Dr. Megan Wallace on grade for the Pfizer-BioNTech COVID-19 vaccine. Dr. Wallace?
Thank you. Good afternoon. Next. The policy question under consideration is, should vaccination with Pfizer-BioNTech COVID-19 vaccine be recommended for persons 12 to 15 years of age under an emergency use authorization? Next. The components of the Pico question are shown on this slide. The population under consideration is persons aged 12 to 15 years. The intervention is 2 doses of the Pfizer-BioNTech COVID-19 vaccine 21 days apart. The comparison is no vaccine. The work group identified the 7 outcomes listed here as the most important for the policy question. Next. The work group felt that the outcomes that needed to be considered for policy should be modified when considering COVID-19 vaccines for adolescent and pediatric populations. The outcomes are compared here, pediatric on left and adult on right, and outcomes that changed are in red. Briefly, symptomatic laboratory-confirmed COVID-19 remains a critical benefit. Given that the size of pediatric trials is smaller, direct efficacy data may not be robust. These studies were designed to assess immunobridging, which can be considered in support of efficacy. Hospitalization due to COVID-19, which is less common in children, remains an outcome, but is important instead of critical. Death, which is rare in children, has been replaced with multi-system inflammatory syndrome in children, but deaths will still be monitored as part of serious adverse events. For harms, serious adverse events remain a critical outcome, and reactogenicity remains an important outcome. Next. Of note, in the case of vaccine trials, hospitalization due to COVID-19 and MIS-C are less common in the phase 3 trials may not be designed or powered to evaluate differences between treatment groups. We do not necessarily expect to have direct evidence for these outcomes at this point, and to some degree can infer that decreases in symptomatic COVID-19 would also translate into decreases in hospitalizations and MIS-C. There were no COVID-19 hospitalizations or cases of MIS-C among vaccinated or placebo participants in the available body of evidence, so these outcomes are not included in the evidence profile I'm going to present. Additionally, for the outcomes of seroconversion and asymptomatic infection, no data are currently available, so these outcomes are also not included in the evidence profile. Next. We conducted a systematic review to identify evidence related to the policy question. We identified published articles using the databases and search terms listed here to identify data on vaccination with the specific vaccine formulation under consideration that involved human subjects, reported primary data, included persons at risk for SARS-CoV-2 infection, included data relevant to the efficacy and safety outcomes being measured, and included data on the dose and timing under consideration. We sought out additional sources, including obtaining unpublished data from vaccine manufacturers. Next. Briefly, over 5,300 records were identified through database searching, and 1 record was obtained directly from the sponsor of the Phase 2-3 trial. Ultimately, 1 resource was included in the evidence synthesis. Next. Grade evidence type assesses the certainty of estimates from the available data. The highest level of certainty is type 1, which means we are very confident the true effect lies close to that of the estimate. Type 2, we are moderately confident in the effect estimate, but there is a possibility the true effect could be substantially different. To type 3, low certainty, indicating our confidence in the effect estimate is limited. To type 4, indicating very low certainty, meaning we have little confidence in the effect estimate. The evidence type is not measuring the quality of individual studies, but how much certainty we have in the quantitative estimates of effect across each outcome. Next. Initial evidence type is determined by the study design. A body of evidence from randomized control trials starts with an initial evidence type of 1, indicating high certainty. A body of evidence from observational studies starts with an evidence type of 3, indicating low certainty. The evidence type can be downgraded due to risk of bias, inconsistency, indirectness, or imprecision. Other considerations could downgrade or upgrade the evidence type. Next. Now I will review evidence of benefits. Next. For the critical outcome of symptomatic COVID-19, 1 study provided data. This was the Pfizer-BioNTech Phase 2-3 randomized control trial, and the data were obtained directly from the sponsor. The data cutoff date was March 13th, 2021. Next. Primary analyses were performed for an evaluable efficacy population, defined as all eligible randomized participants who received all vaccination as randomized within the predefined window and have no other important protocol deviations as determined by the investigator, and who did not have evidence of prior SARS-CoV-2 infection. For these analyses, there were over 1,900 persons, about 1,000 per arm, who contributed 300 person-years of observation, about 150 per arm. Secondary analyses included persons with prior infection. Analyses were also done for an all-available efficacy population, which includes all randomized participants who received at least 1 dose, with outcomes counting any time after that. It may be helpful to think of the evaluable efficacy as similar to a per-protocol analysis, and the all-available efficacy as similar to an intention-to-treat analysis. Next. Using the evaluable efficacy population for all persons aged 12 to 15 years, there were 0 cases among 1,001 persons in the vaccine arm and 16 cases among 972 persons in the placebo arm, which resulted in a vaccine efficacy estimate of 100%. This is the outcome used for grade. Next. Varying timing of outcome assessments and with inclusion of persons who had evidence of prior infection, as highlighted by the red box, had little influence on the efficacy estimates. Next. The phase 2-3 trial was designed and powered to use immunobridging to evaluate efficacy. Immunobridging studies compare immunogenicity in a group of interest, for example, those aged 12 to 15 years, with a comparison group in which efficacy has been demonstrated in clinical trials, for example, those aged 16 to 25 years. For the immunogenicity analyses, 209 participants aged 12 to 15 years and 186 participants aged 16 to 25 years were randomly selected from the vaccine and placebo arms of the trial for comparison. Next. The immune response to vaccine was evaluated using the geometric mean ratio of neutralizing antibody titers comparing adolescents to young adults. Non-inferiority criteria are met when the lower bound of the 95% confidence interval for the geometric mean ratio is not less than a preset value, which for this study was 0.67. The immune response to vaccine in adolescents aged 12 to 15 years was non-inferior to that observed in young adults aged 16 to 25 years, with a geometric mean ratio of 1.76 based on SARS-CoV-2 neutralizing titers at 1 month after dose 2 in participants without prior evidence of SARS-CoV-2 infection. In fact, antibody levels were significantly higher among adolescents aged 12 to 15 years than young adults aged 16 to 25 years. Next. For the sake of transparency, we would also like to mention additional analyses from the study that compared seroresponse in adolescents and young adults. These analyses are considered exploratory because there is not yet an established immunological correlate of protection. Among participants without prior evidence of SARS-CoV-2 infection, 97.9% had at least a 4-fold rise in SARS-CoV-2 neutralizing titers from before vaccination to 1 month after dose 2. The difference in proportions of participants who had at least a 4-fold rise between adolescents and young adults was 2.1%, but the difference was not significant. Next. Here is the grade evidence table for the outcome symptomatic COVID-19. Because the data were from a randomized control trial, the evidence type started at 1. Regarding risk of bias, there was some concern related to blinding. Participants and study staff were blinded to assignments, but they may have inferred receipt of vaccine or placebo assignment based on reactogenicity. This was deemed unlikely to overestimate the efficacy results. Therefore, we consider the risk of bias to be not serious. Because there was only one study, there was no serious concerns of inconsistency. Some concern for indirectness was noted due to the short duration of observation in the available body of evidence. The vaccine efficacy observed at a median 2-month follow-up may differ from the efficacy observed with ongoing follow-up. However, in consideration of the strength of association, it is unlikely that the efficacy estimate for symptomatic COVID-19 would change substantially enough to fall below the FDA-defined efficacy threshold for licensure under an emergency use authorization, that is, to less than 50% efficacy. We also note that longer-term efficacy from the adult randomized control trial suggests that short-term efficacy will translate to longer-term efficacy. Further, the immunobridging data indicate that the immune response in adolescents is at least as strong as that observed in adults. This leaves us with a final certainty of type 1. Next. Next, I will share data on grade for harms. Next. The phase 2-3 trial was the only study to provide data on serious adverse events. Next. Here are the raw data on the critical outcome serious adverse events. In the phase 2-3 trial, there were 5 events among the vaccine group and 2 among the placebo group. None of the events were considered to be associated with vaccination. Next. The grade evidence table for serious adverse events is shown here. The relative risk of serious adverse events between vaccinated and placebo was 2.5, with a 95% confidence interval of 0.49 to 12.84. The certainty assessment was reduced 1 point due to serious concern of indirectness, because the body of evidence does not provide certainty that rare serious adverse events were captured due to the short follow-up and sample size. There was also very serious concern for imprecision due to the confidence interval crossing the line of no effect and the width of the confidence interval containing estimates for which different policy decisions may be considered, leaving us with a final certainty of type 4. Next. Reactogenicity was evaluated using the same phase 2-3 study. Next. The events and grading scales used in the study are shown here. The local reactions solicited for the 7 days following vaccination were injection site pain, redness, and swelling, and the systemic events solicited were fever, vomiting, diarrhea, headache, fatigue, chills, new or worsened muscle pain, and new or worsened joint pain. Next. In the phase 2-3 study, grade 3 local reactions or systemic events were reported in 10.7% of persons in the vaccine arm and 1.9% of persons in the placebo arm. Most of these events were grade 3, with one grade 4 event of pyrexia reported in a vaccine recipient. Next. The relative risk for any grade 3 or 4 event was 5.49 with a 95% confidence interval from 3.51 to 8.58. There was no serious concern for risk of bias, inconsistency, indirectness, or imprecision. The final certainty was type 1. Next. This table summarizes our grade assessment for the Pfizer-BioNTech COVID-19 vaccine in adolescents. In terms of benefits, the available data indicate that the vaccine is effective for preventing symptomatic COVID-19 with direct efficacy data and supplemental immunobridging data with an evidence type of 1. No data were available to assess the other potential benefits. In terms of harms, a total of 5 serious adverse events were observed in the vaccine arm and 2 in the placebo arm. There was concern for indirectness, and the wide confidence interval included both benefits and harms, so the evidence type was 4, indicating very low certainty. No SAEs were judged to be related to vaccination. Regarding reactogenicity, severe reactions were more common in vaccinated persons, and 10.7% of vaccine recipients versus 1.9% of placebo recipients reported grade 3 or 4 reactions. The evidence type for reactogenicity was type 1. Next. In conclusion, the phase 2-3 randomized control trial of the Pfizer COVID-19 vaccine was conducted among persons aged 12 to 15 years in the United States. The vaccine efficacy estimate for the Pfizer-BioNTech COVID-19 vaccine in adolescents was 100% for symptomatic laboratory-confirmed COVID-19. Serious adverse events were more common among vaccine than placebo participants, but there was very low certainty in the estimates. No serious adverse events were judged to be related to vaccination. Grade 3 or 4 local or systemic reactions were more common among vaccine than placebo recipients and were reported by about 11% of vaccinated subjects. The certainty in the estimates for critical benefits was type 1, high. The certainty in the estimates for critical harms was type 4, very low. Next. I would like to acknowledge the contributions of everyone listed here, in particular Julia Gargano, Amy Blaine, and Danielle Mulia, who have been instrumental in reviewing the data. Next. Thank you.
Thank you very much, Dr. Wallace. Are there any questions from the voting members? Not seeing any. Oh, Dr. Daly, please go ahead.
Thanks for that outstanding presentation. Can you just remind us about the strength of evidence around serious adverse events for the adult trial, and then contrast that with what we're seeing here for the trial in 12 to 15-year-olds? Thank you.
Yes, and I think we might have a backup slide for this, but if I'm remembering correctly, I think that the serious adverse events was type 2 in the adult trial. I remember specifically that the 95% confidence interval did not pass the line of no effect. There was more certainty in the evidence, but we did downgrade 1 for indirectness for the same reason that we downgraded in the adolescent trial.
Great, thanks so much.
Are there any other voting members with questions? Liaisons, any questions from your And Dr. Paling.
Yes, thank you for a great presentation. I did want to ask, when you reviewed the data, was there any cases of having allergic reaction or?
Not in the 12 to 15-year-olds.
Okay, thank you.
Liaisons, any questions? One more time back to the voting members. Seeing none, last call for questions. Very good. Again, thank you, Dr. Wallace, for this excellent presentation. Let's move on to the next presentation by Dr. Sarah Oliver on evidence to recommendation framework for the Pfizer-BioNTech COVID-19 vaccine in adolescents 12 to 15 years. Dr. Oliver, please.
Thanks, Dr. Romero. Next slide. Next slide. So we have done this a few times before, but highlighting again that the evidence to recommendation framework allows us to describe the evidence to inform ACIP recommendations in a transparent manner. Next slide. This is our policy question for today. Should vaccination with the Pfizer-BioNTech COVID vaccine be recommended for persons 12 to 15 years of age under an EUA? Next slide. As was just shown in grade, this is the Pico question with the updated outcomes for adolescents. Next slide. These are the ETR domains with the questions asked for each of the domains that we'll walk through today. Next slide. And we'll be updating the intervention with the Pfizer-BioNTech COVID vaccine given to adolescents aged 12 to 15 years, and the problem as COVID-19 among adolescents aged 12 to 15 years. Next slide. So first for the public health problem. Next slide. Which asks, is COVID-19 among adolescents aged 12 to 15 years of public health importance? Next slide. This slide shows a review of the evidence that we'll walk through today with a focus on adolescents, COVID incidence and burden estimates, COVID-associated hospitalization and mortality, and then updates on MIS-C and transmission. Next slide. This is the overall epicurve of the pandemic. There have been over 32 million cases of COVID reported to CDC, with the most recent 7-day moving average of 38,000 cases per day. Cases have declined in recent weeks after a slight uptick in late March and early April. Next slide. So next we'll highlight data in this adolescent population. I want to point out that much of the surveillance data in the US uses a 12 to 17 year age group, so much of the epi data will be presented with this age cutoff. Through the end of April, there have been over 1.5 million cases among adolescents 12 to 17 years of age. Next slide. Then this slide shows the proportion of total COVID cases by age group throughout the pandemic. You can see that early in the pandemic, the older adults, shown in darker orange, represented a larger proportion of cases. However, that proportion has decreased in recent weeks. As more adults are vaccinated, adolescents aged 12 to 17 years make up a larger, greater proportion of total cases. In April, 9% of cases were aged 12 to 17 years, which actually represents a larger proportion of total cases than adults 65 years of age and over. Next slide. However, we know that diagnosed and reported cases are an underestimate. To better reflect the burden of COVID-19, the full impact of disease, CDC provides estimates of COVID-19 infections, symptomatic illness, and hospitalizations using a statistical model to adjust for cases that national surveillance networks are unable to capture for a number of reasons. For children and adolescents 5 to 17 years of age, there have been an estimated 22 million SARS-CoV-2 infections, making up around 19% of all estimated SARS-CoV-2 infections. Next slide. Then these numbers are based off of those burden estimates. These are the estimated rates of SARS-CoV-2 infections in green, symptomatic illness in gray, and hospitalizations in red. These are the rates per 100,000 population by age group. Children and adolescents 5 to 17 years of age have the highest rates of infection and symptomatic illness. However, the proportion of symptomatic patients that are hospitalized are lower among children. Next slide. So then moving to hospitalization. This chart shows the cumulative rates of COVID-associated hospitalizations for age groups for children and young adults from March of 2020 through the end of March of 2021 from COVIDnet surveillance, which is a population-based surveillance system that collects data on lab-confirmed COVID-associated hospitalizations among children and adults through a network of over 250 acute care hospitals in 14 states. The red line illustrates the rate for persons aged 12 to 17 years, which was 51 per 100,000 population. Rates for this age group have consistently been higher than those in persons aged 5 to 11 for most of the pandemic. Next slide. Now we'll highlight recent hospitalization rates in this pediatric and adolescent population. Next slide. So the last slide showed cumulative hospitalization rates. This graph depicts the three-week moving average rate of hospitalizations among children and adolescents. Over the past 2 months, there has been a gradual increase in the hospitalization rate among adolescents 12 to 17 years, shown here in red. Next slide. So then to provide some additional context to these hospitalization rates, here we're showing the cumulative COVID-19 associated hospitalization rates among adolescents 12 to 17 years by MMWR week in yellow, compared to the cumulative influenza associated hospitalization rates during the H1N1 pandemic year from 2009 to 2010 from historic FluServeNet in blue. Cumulative hospitalization rates for adolescents aged 12 to 17 years is 51.3 per 100,000 population and 23.9 for H1N1 influenza. Next slide. Then here we add the last several influenza-associated hospitalization rates for 3 of the most recent flu seasons, 2017 and 18, 18-19, and 19-20, shown in green, red, and gray, ranging from 12 to 15 per 100,000. Of note, the flu season cumulative hospitalization rates, the flu season starts at MMWR week 40, so these accumulate over a shorter period of time. Next slide. So then to continue with COVIDnet, these results are from an investigation of 722 hospitalized adolescents. Demographics are shown here on the right. Over half of the children were Hispanic or non-Hispanic Black. 31% had severe disease defined as requiring ICU admission or invasive mechanical ventilation during hospitalization. Next slide. And 61% of children had at least one underlying condition, which is shown in the figure on the left, the most common being obesity, asthma, developmental delay, or diabetes. Next slide. So now we'll move to COVID-related deaths. There have been nearly 580,000 deaths in the US, with the most recent 7-day moving average of 604 deaths per day. Next slide. These are counts of COVID-19 associated deaths between January 1st of 2020 and April 30th of 2021. There were 127 COVID-19 deaths among adolescents 12 to 17 years of age, which accounted for 1.3% of all deaths among adolescents during the same time period. While this sounds low, it's worth noting that this would still be in the top 10 causes of deaths among children in 2019, which is the last year that we have top 10 causes of death for comparison. Next slide. So next, moving to multi-system inflammatory syndrome in children, or MIS-C. This is a severe hyperinflammatory syndrome occurring 2 to 6 weeks after acute SARS-CoV-2 infection, resulting in a wide range of manifestations and complications. 60 to 70% of patients with MIS-C are admitted to intensive care, and 1 to 2% die. There have been 3,742 MIS-C cases reported to national surveillance as of early May. The median age was 9, with 21% of cases occurring in adolescents 12 to 17 years of age. 63% of cases occurred in children who are Hispanic or non-Hispanic Black. And MIS-C has an estimated incidence of 1 to 8.5 MIS-C cases per million person months. Next slide. So while adolescents may have a slightly lower incidence of MIS-C compared with younger children, they generally present with more severe MIS-C. Compared with MIS-C patients aged 0 to 5 years, both ICU admission and decreased cardiac function were more likely in patients 13 to 20 years hospitalized with MIS-C. Next slide. Then for adolescents and transmissions. Some studies observed similar infection rates between children and adults, while others found lower infection rates among children compared to adults. Adolescents may be more likely to be infected than younger children. This is supported by data from several different methods, including contact tracing, test positivity, and population-based seroprevalence data. Secondary transmission from adolescents can and does occur. While SARS-CoV-2 transmission among students is relatively rare, several studies suggest transmission is more likely within high school settings than in elementary school settings. Next slide. Multiple outbreak and contact tracing investigations have demonstrated efficient transmission among children, adolescents, and young adults, including transmission to older, more vulnerable household members. Next slide. These are the result of a recent publication in Science describing results from a survey of over 1.5 million adults, including over 500,000 who were living with at least one child in school. The survey found that after adjusting for county-level incidents and other factors, but not necessarily school-based mitigation measures, living in a household with a child engaged in full-time in-person school was associated with a substantial increase in the odds of reporting a COVID-like illness in green, loss of taste or smell in orange, or a positive SARS-CoV-2 test in purple within the previous 14 days, compared to those with children not attending in-person school. The strength of association increased with grade in the school, with the adolescent ages highlighted here in the red box. The association between COVID outcomes and reporting a child in the household was attenuated somewhat when that child was attending part-time schooling, shown on the right. Next slide. So overall, in summary, adolescents 12 to 17 years of age are at risk of severe illness from COVID-19. There have been over 1.5 million reported cases and over 13,000 hospitalizations to date among adolescents 12 to 17 years. Overall, the hospitalization rate for COVID in this population is higher than the influenza-associated hospitalization rate for the same age group during the 2009 H1N1 flu pandemic. And the clinical presentation of MIS-C is more severe in adolescents than in younger children. In addition, COVID in adolescents may also indirectly impact others' health. Adolescents contribute to transmission in household and communities, including older vulnerable populations. And finally, adolescents represent an increasing proportion of recent COVID cases. Next slide. So based on the review of this data, the work group felt that yes, COVID disease among adolescents is of public health importance. Next slide. So moving to benefits and harms. Next slide. We'll answer the question, how substantial are the desirable anticipated effects? Next slide. And undesirable effects? Next slide. And if those desirable effects outweigh the undesirable effects? Next slide. We just had a presentation for grade, so I won't go through in detail, but overall efficacy of the vaccine was supported by both immunobridging data and clinical efficacy. The clinical trial from the Pfizer vaccine demonstrated efficacy against symptomatic lab-confirmed COVID with an estimate of 100%, graded with a high certainty of evidence. Next slide. Then regarding the immunobridging data, the geometric mean ratio for antibodies in the 12 to 15-year-olds compared to the 16 to 25-year-olds was 1.76, which met the non-inferiority criteria. No hospitalizations due to COVID or cases of MIS-C were reported by any trial participants. Next slide. Then moving to potential harms, serious adverse events were reported in a higher proportion of recipients of vaccine versus placebo, based on 5 SAEs in the vaccine group and 2 in the placebo group. This was graded at a very low certainty of evidence. And severe reactions were more common in the vaccine recipients, where a grade 3 or higher reaction was reported by 10.7% of vaccinated versus 1.9% of the placebo group. And this was also graded with a high certainty of evidence. Next slide. No deaths were reported among any of the trial participants. Local reactions within 7 days were common, occurring in 91% of vaccine recipients, with pain at the injection site as the most common. Systemic reactions were common as well, with fatigue and headache as the most common, and most symptoms resolved within 1 to 2 days. Next slide. Then regarding other events of interest that we've been following with the Pfizer and mRNA vaccines, no cases of anaphylaxis were reported in the adolescent, the 12 to 15 years of age study participants. No cases of Bell's palsy or facial paralysis were reported in adolescents. And there were 7 participants in the vaccine group that had lymphadenopathy compared to 1 participant in the placebo group. Most lymphadenopathy was local in the arm or neck region, occurred on the same side as vaccination, and was reported within 2 to 10 days after receiving the vaccine. Next slide. Then this is a summary of the grade evidence types from the prior presentation. Next slide. So the work group felt that the desirable anticipated effects were large. Next slide. And that the undesirable effects were small. Next slide. And that the balance favored the intervention, the use of the Pfizer-BioNTech COVID vaccine. Next slide. Moving to values. Next slide. Which will address how the target population feels with the balance of desirable to undesirable effects. Next slide. And if there's variability in these outcomes. Next slide. So we continue to review our scientific literature, news media, and reports, but limited surveys conducted since authorization of the COVID vaccines. Next slide. This figure shows the overall proportion reporting positive vaccine intentions by month of data collection, with bubbles proportional to the survey sample size. The surveys were conducted among adults asking about their intent to receive vaccine for themselves. There's been a steady increase in intent to be vaccinated among adults. Next slide. Then when evaluating surveys among parents regarding their intent to have children vaccinated, among the surveys, found 46 to 60% of parents surveyed said they plan to get their children vaccinated. The most common reasons for not planning to vaccinate their children included not being sure it's safe or that the vaccine was developed too quickly, that they don't trust information about the vaccines, or don't have enough information. Generally, parents reported a similar or slightly lower intent to vaccinate their children compared with the intent to vaccinate themselves. Next slide. It was found that the intent to vaccinate children differed by parents' gender, age, and income status. Fathers were more willing to vaccinate their children than mothers. Older mothers were more willing to vaccinate their children than younger mothers. And higher income households were more likely to report an intent to vaccinate, where lower income households were twice as likely to say they were not sure about vaccinating their children compared to these higher income households. Next slide. Then when evaluating parents' intent for children to receive their vaccine, you can see that this intent varies by race and ethnicity, which is similar to the overall intent to get vaccinated among adults. Next slide. When adolescents were asked about their intent to get vaccinated on the left, you can see that 51% reported that they would definitely or probably get vaccinated. Parents in this same survey, although not necessarily paired parents to the adolescents interviewed, reported that 55% would definitely or probably get their adolescent vaccinated. Next slide. Then parents were asked how concerned they were about their adolescent getting COVID-19 and asked how they were, if they were concerned about their adolescent having any side effects from the COVID-19 vaccines. Adolescents were asked these questions about themselves. In both samples, respondents reported moderate levels of concern about both adolescents getting COVID and adolescents having side effects from COVID vaccination. Values for concern about the COVID vaccine side effects were slightly but significantly higher than values for concern about COVID disease in both populations. Next slide. So in summary, about half of parents say they're likely to get their adolescent vaccinated. The intent to vaccinate adolescents differed by parents' gender, race, and income. The intent to vaccinate adolescents were similar or slightly lower than parental intent to get vaccinated themselves. And there was overall limited information on adolescent intent to get vaccinated themselves. However, one study did find that nearly 40% of adolescents said they would let their parents or caregivers decide if they would get the vaccine. Next slide. So when the work group was asked if the target population felt that the desirable effects were large relative to undesirable effects, answers varied. Many felt that they were moderate to large, but ultimately most said that it varies. Next slide. So not surprisingly, when asked if there was variability in how people value the outcomes, they felt that there was probably important or uncertainty or variability. Next slide. So moving to acceptability. Next slide. The work group was asked if the Pfizer vaccine is acceptable to key stakeholders. Next slide. We were able to conduct a pulse survey of the jurisdictions in mid-April for their implementation planning for adolescents. Overall, most jurisdictions were taking a multi-pronged approach using existing provider networks, pediatric providers, and school-based clinics. Next slide. In addition, there was a survey late last year about physicians' willingness to administer the COVID vaccine in their practices. Overall, 97% of providers were willing to administer COVID vaccine. The largest perceived barrier to vaccination was parent or patient concern about the safety of COVID vaccines. Next slide. Then this is a result from another parent survey asking the location where parents would be the most comfortable receiving a COVID vaccine. You can see on the far left in green, parents were the most comfortable being vaccinated at their regular doctor's office, with the local pharmacy as next. Next slide. So overall, most jurisdictions are utilizing a variety of implementation strategies to vaccinate adolescents. Nearly all primary care providers surveyed are willing to provide COVID vaccines to their patients. And adolescents and their parents report their greatest comfort with receiving COVID vaccines at their primary care providers' offices. Next slide. So the work group felt that yes, the Pfizer vaccine was acceptable to key stakeholders. Next slide. So moving to feasibility. Next slide. Asking if the vaccine is feasible to implement among adolescents 12 to 15 years of age. Next slide. So the objective of adolescent vaccination is to promote adolescent vaccination as quickly and equitably as possible, which will require a multi-pronged approach. Jurisdictions and providers already are vaccinating adolescents 16 to 17 years of age. Current implementation plans to expand this down to 12 include leveraging current COVID vaccine infrastructure and adapting over time. This would include an early summer sprint in May and June, followed by increasing access in June and July, and a back-to-school campaign later in the summer and at the start of the school year. Next slide. This will require a stepwise approach to increasing vaccine access for adolescents. Phase 1, or augmenting additional existing infrastructure for vaccination. includes all current COVID vaccine providers opening up to allow vaccination for children 12 and over. Then, phase 2 involves strategically adding providers serving adolescents, including larger provider groups in children's hospitals, as well as smaller providers needed to increase access, such as those in areas with high social vulnerability and rural areas. Then phase 3 includes utilizing school-based vaccination programs in partnership with public health, pharmacies, and third parties, as well as through HRSA sites. Next slide. So this is a bit more information on each of these approaches. Increasing access through primary care providers serving adolescents has the benefits of utilizing trusted providers for providing information and education about COVID vaccines, as well as vaccinating against COVID, but to manage routine vaccinations, particularly as students return to school in the fall. Pharmacies and HRSA sites have a broad footprint across the nation and can rapidly expand to provide COVID vaccines for adolescents. School-based vaccinations have the benefit of reaching adolescents in their own communities, as well as being trusted sources of information for communities. Schools can partner with FQHCs, pharmacies, and/or public health to hold targeted programs to improve coverage, particularly as students return. Next slide. There are a few additional implementation considerations. Current cold chain storage requirements and package size may limit the ability of COVID vaccines, particularly to smaller primary care providers. There are recent updates to both cold chain and package size requirements that could improve this, however. Secondly, for the short term, Pfizer is the only vaccine available, could be the only vaccine available for this population, and jurisdictions and vaccine providers may need to determine a process for allocation of this product for this age group. And third, for consent and assent. There are no federal legal requirements for caregiver consent of COVID-19 vaccine or any other vaccine. However, COVID vaccine must be administered according to applicable state and territorial vaccination laws, including those related to consent. Sites administering vaccines should follow the current state and jurisdictional policies and practices for other routine immunizations in this age group. Next slide. So the work group felt that overall, the Pfizer vaccine is feasible to implement among adolescents. Next slide. Moving to resource use. Next slide. Addressing if the Pfizer vaccine given to adolescents is a reasonable and efficient allocation of resources. Next slide. The US government has purchased 600 million doses of mRNA vaccines, with 300 million doses of the Pfizer vaccine. These vaccines will be available at no cost. There are no studies that evaluate the cost effectiveness around the use of COVID vaccines among adolescents. However, vaccinating adolescents may allow for a greater confidence in a safe return to schools. Vaccination could lead to reduced work and school absenteeism related to COVID quarantine and isolation. And there was one study that estimated that over time, school closures could have a total economic loss as high as $15 trillion over a lifetime. Next slide. The work group concluded that cost effectiveness may not be a primary driver for decision-making during a pandemic and for a vaccine used under EUA. However, it will need to be reassessed for future recommendations. The use of COVID vaccines in as many populations as possible, including adolescents, will be important to returning to pre-pandemic activities. This return to pre-pandemic activities is likely to have an overall positive economic impact. Next slide. So the work group felt that yes, during a pandemic, the use of the Pfizer vaccine among adolescents is a reasonable and efficient allocation of resources. Next slide. And finally, equity. Next slide. What would be the impact of the Pfizer vaccine given to adolescents beyond health equity? Next slide. Health equity is when everyone has the opportunity to be as healthy as possible and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. We identified groups that might be disadvantaged in relation to COVID-19 disease burden or receipt of a COVID vaccine using the Progress Plus framework. We've used this process previously for other ETRs. Evidence related to this group was gathered through a review of scientific and gray literature, as well as review of the CDC COVID-19 response data and resources. Next slide. These are the groups that we've identified as being disadvantaged in relation to COVID-19 disease burden or receipt of the Pfizer-BioNTech COVID vaccine, and we'll go through evidence on the next slide. Next slide. The following grid demonstrates where published, peer-reviewed literature is available describing either disproportionate COVID-19 morbidity and mortality among adolescents, specifically in the first column, or among adults in the second column, which we can infer may apply to adolescents. Additionally, in the last column shows where data are available demonstrating general barriers to healthcare in each of these populations. It's also important to point out that there is diversity within each of these groups, as well as significant intersections between these groups. For example, Black and Indigenous adolescents and adolescents who are LGBTQ+ are considered overrepresented among the homeless youth populations. Next slide. This slide shows the percent of persons fully vaccinated in orange compared to the percent of the US population in gray. As of May 4th, a lower percentage of Black and Hispanic or Latino adults were fully vaccinated compared with the percentage of these groups in the overall population. While this data is specific to adults, we may see similar patterns in adolescents. Next slide. And again, there's two characteristics of the Pfizer-BioNTech COVID vaccine that have the potential to impact health equity: cold chain storage, handling, and administration requirements, and the need for a 2-dose series. New data recently submitted to FDA on stability may reduce the need for ultra-cold storage, thereby increasing access, particularly in smaller providers. Additional support to efficiently utilize doses, as well as smaller tray size, would also improve access. The requirements for a 2-dose series will make follow-up challenging for some disadvantaged groups, such as those who are homeless, live in rural locations, and have limited to no access to healthcare. Within adults early in the vaccination program, only a small proportion didn't receive the second dose of a 2-dose series. However, differences were seen by jurisdiction, race, ethnicity, and age. And overall, the multi-pronged approach described earlier to implementation can improve access and overall can improve equity. Next slide. The work group felt that the impact of the Pfizer vaccine would probably increase health equity. Next slide. Next slide. So then this slide highlights all of the work group judgments for each of the ETR domains. Next slide. After reviewing the data, the work group provides a judgment on the balance of consequences. Starting on the left, where the undesirable consequences outweigh desirable consequences, and on the right, where desirable consequences outweigh undesirable consequences. Next slide. The work group felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. In addition, after reviewing the totality of information presented in the evidence to recommendation framework, the work group discussed the type of recommendation proposed to ACIP. The options are: we do not recommend the intervention, we recommend the intervention for individuals based on shared clinical decision-making, and we recommend the intervention. Next slide. Based on the totality of data presented, the work group has proposed to recommend the intervention to ACIP. Next slide. I want to thank all of the people who have worked very hard to put this together. I'll notice that many people on the slide were the same people that did everything for the Janssen safety. So there was a fast and rapid pivot to get this ready. So I want to thank all of them, as well as people across the response who helped us pull this data together. Next slide. Thank you.
Thank you very much, Dr. Oliver. You've delivered as the ACIP has become accustomed to another outstanding presentation. And I'll open it up to see if there are any questions from the voting members at this time.
Dr. Romero, as we're waiting for people to raise their hand, I just wanted to let you know that Dr. Beth Bell is on the line and can introduce herself.
Thank you very much. Thank you. Welcome, Dr. Bell. It appears you left the voting members speechless. Are there any liaisons that wish to ask questions?
Dr. Romero, can you just let Dr. Bell announce herself and indicate any conflicts of interest so we have that documented?
I can do so. Please, Dr. Bell.
Beth Bell, clinical professor, University of Washington, no conflicts.
Thank you. Welcome. Let's go back to questions then. Dr. Bernstein.
Thank you, Dr. Oliver. Spectacular presentation as always. I have three questions. One is, I understood that those children 12 to 17-year-olds were more likely to have cardiac dysfunction and so more acting more like adults. Do we know the outcome of those children as far as the duration of cardiac dysfunction, or are they considered so-called long haulers?
Dr. Bernstein, I'll say the cardiac dysfunction were specifically patients who were diagnosed with MIS-C. And Dr. Melger, I think, is on. Do you want to comment on kind of the outcomes, the cardiac outcomes on those?
Hi, yeah, this is Michael Melgar. I'm part of the CDC COVID-19 response, specifically in the multi-system inflammatory syndrome unit. Yes, what Dr. Oliver said is exactly right. So specifically, adolescents who develop MIS-C do tend to have a phenotype that is somewhat different from the younger children in that they do develop more often systolic dysfunction biventricular. While a lot of the children do recover the cardiac function relatively quickly, long-term studies are still needed to sort of characterize what the long-term complications could be of among MIS-C survivors.
Thank you. The second question I had is lower income households were twice as likely to say they were not sure about vaccine and less likely to report intent to vaccinate. Is there any focus group data as to what information would be most helpful to encourage vaccination for those that were not sure?
Thanks, Dr. Bernstein. We have an entire group here within the vaccine task force focused on the Vaccinate with Confidence. And there is an entire Vaccinate with Confidence website with information on this. And I know that their work is very focused on specific outreach to potentially hesitant groups and ways to target to improve confidence in those populations.
Thank you. And the third question I had is, do we know anything about how the impact of the loss of a family member from COVID-19 has influenced the family's decision around intent to vaccinate?
That's an excellent question. I don't know that I have specific data to point to that, although we can keep our eye out for that if we bring you an ETR presentation for adolescents in the future.
Thank you.
Thank you very much. Next, Dr. Hogue.
Thank you, Dr. Oliver, for a fantastic presentation, very informative. I want to go back to a couple of slides that you presented. I don't have the slide numbers in front of me, but they're the two slides relative to the strategy for implementation of vaccine for adolescents. And I want to compare and contrast it perhaps to the adult strategy. With the adult strategy, because of limited supplies of vaccine, there was an intentional approach of tiering and putting vaccine out in hospitals first and then in different settings. I think what you were suggesting here, if I understand correctly, is that the three strategies that are presented could be implemented by the states at any point, that it's not intended that those have to be tiered or staged in any way, but that they can be implemented simultaneously and are just to try to get our jurisdictions thinking about different strategies and approaches. Am I interpreting that correctly, or is there a different intent?
No, you're absolutely interpreting that correctly. And the jurisdiction survey, when we asked them, showed that they absolutely are planning on doing this multi-pronged approach, not necessarily sequentially, but as a whole.
Thank you very much.
Dr. Paling.
Thank you very much for a wonderful presentation. I wanted to go back and look at the slide about the 772 children in COVID-19 that were hospitalized. And in there, we did see, if I remember it correctly, about 31% were non-Hispanic Black and 32% were Hispanic. And then we also were looking at the high-risk condition. And have you had a chance? Yes, that's exactly the slide. And do we know if there was a disproportionate amount of high-risk conditions among the non-Hispanic Blacks and Hispanics?
Thanks for that. We actually have one of our COVID-19 experts on the line. Rebecca Woodruff, are you able to comment on that?
So this is Fiona Havers from COVID-19.
Or Fiona, sorry.
We do have these data. We haven't analyzed them separately for 12 to 17, but in general, we have seen in all of our data, we have seen consistently higher amounts of underlying conditions in non-Hispanic Black and Hispanic young persons.
Okay, thank you.
Dr. Stinchfield.
Yeah, thank you, Dr. Oliver. Another great presentation. I have a question for anybody on the cold chain updates and packaging changes comments. I just wondered if someone could detail those updates a little bit more, especially at timeline.
Yeah. I was going to see if FDA could respond to that, please.
I'm sorry, could you repeat the question?
Sorry.
Sure, Dr. Fink. I was just wondering about if you could update us on the cold chain changes and packaging changes, if there's some details you can share, especially at timeline.
I'm sorry, unfortunately, there are not details that I can share at this time.
Thank you.
Thank you very much. Dr. Howell.
Hi, Molly Howell with AIM. I'm just wondering if in the work group discussions, especially around feasibility, if there was any discussion around other adolescent vaccines and the impact COVID vaccination and spacing with other adolescent vaccines would potentially have on HPV, meningococcal, Tdap vaccination rates and back to school immunizations, and if that was taken into consideration at all.
Thanks. Absolutely, it was. The work group discussed this, and we actually, in the next presentation, will go over some of the clinical considerations around use of the vaccine, which includes co-administration.
Thank you. Dr. Freihofer, excuse me.
Sandra Freihofer, American Medical Association, speaking as a practicing general internist. Dr. Oliver, as usual, a great and clear presentation, and I think you've clearly made the point that adolescents are at increased risk of severe disease, and they can contribute to transmitting COVID to other older and vulnerable populations. I wanted to piggyback on the request to find out more details on when the cold storage and packaging will be further delineated. As we think about the summer sprint and the back-to-school vaccination clinics, this could be so important for helping get our patients vaccinated. Also, in your presentation, you mentioned that the government has purchased 600 million doses, and perhaps we ought to prioritize that just for kids. As a practicing physician, I really think I don't want to turn people away. So my hope is that when a family comes to an office or to any sort of place to get vaccinated, if there's vaccine available, you can vaccinate the family and not turn them away because they're not allowed to get that particular vaccine.
Dr. Freihofer, I think that this is Dr. Cohn. Just to clarify, I don't think it was suggested that the Pfizer vaccine only be given to adolescents. It was just saying that plans will need to be made to make sure adolescents have access to the Pfizer vaccine in the settings in which they may be vaccinated. But thanks for that.
Thank you for that clarification. Thank you.
Thank you. Dr. Long.
Yes, I wonder if you could comment whether the committee deliberated on the fact that in the Pfizer studies, although we saw that the age group 12 to 15 and the older ones were equally represented by Blacks and Hispanics, they were both very much underrepresented compared with the population and underrepresented compared with this age group at risk of hospitalization and severe outcome. And although I don't really worry too much about biologic plausibility of a different response, it's just too bad that we can't have some of more of these more vulnerable populations considered. So one is, did you think about that or think about that being a concern? Because probably there were very few Hispanic and Blacks who were really in the study. I didn't do the math, but it was a small percent of a not very large study who actually got the vaccine. And the other, you didn't mention the psychiatric. So did you concur with the FDA that although it was noted, it was not of concern?
Thanks. Yes, the work group has always continues to support and really try to push for as diverse populations as we can get in clinical trials to really reflect the population that is in the U.S. where the vaccine would be used broadly. So that was absolutely encouraged or brought up by and discussed by the work group. Then regarding the psychiatric SAEs that were noted, a very similar discussion to what was had shortly happened on the work group as well. So highlighted, asked questions to the manufacturer with similar responses, and ultimately was found that the plausible alternative explanations existed. So they felt comfortable moving forward, but absolutely asked very, very similar questions to the manufacturers and had very similar discussions to what just occurred.
Thank you.
Dr. Maldonado.
Thank you, Dr. Romero, and thank you, Dr. Oliver, for that wonderful presentation. I just wanted to make a comment regarding the overall review and evidence recommendations. I think as a pediatrician and infectious disease epidemiologist and a member of the AAP Red Book Committee or COID, we are really supportive of the data that you've presented so far. We recognize that there are some gaps in information that need to be collected, but we don't really think that these should be considered barriers to moving forward. I agree that those would be areas that could be investigated with time, but this is an urgent problem. We're seeing mortality rates in children that are showing us that this is one of the top 10 causes of death in children under 18. Now, granted, we aren't seeing the tens of thousands of deaths that we are seeing in adults, but children don't die at the same rates overall. And the fact that in several different data sets, we're seeing this pandemic cause deaths in children that are unprecedented is a critical need, and we support the findings that the committee and the working group have put together. Thank you.
Thank you for those comments. Dr. Paling.
Yes, I wanted to build off of what Dr. Long was talking about and wanted the input of the committee about the underlying conditions represented in the children in the study.
Sorry, do you mind clarifying just a little bit the underlying?
Yes. So for the children that were enrolled in the study, did they reflect the medical conditions you showed on the hospitalizations? And did it include children with asthma and children with obesity and other medical conditions?
We do know that the inclusion criteria for the clinical trial was similar to that was seen in adults, where they allowed individuals with kind of stable underlying medical conditions. I don't have a number right off for you. Maybe about 20% of individuals of adolescents in the trial had an underlying medical condition. Yes, that.
Thank you. That's very helpful.
Okay.
Dr. Freihofer, I see that your hand is up. Do you have another question?
I apologize.
No need. Let me ask you a question, Dr. Oliver. So on your values on the parents' intent to receive, children to receive the vaccine, COVID-19 vaccines by race and ethnicity, in both of the surveys, Hispanics were over 50% indicating they would administer it for their children. The question that I had was, did English as a primary or secondary language impact at all on that?
Dr. Romero, I'd have to look a little bit additionally at those two surveys that we showed to get back to you on that specifically. So I will do that and follow up with you. But I will absolutely say that, one aspect of the Vaccine with Confidence team is preparing information in multiple languages, and that this is an area of focus as well.
Yes, thank you very much. Are there any other questions from the voting members or the liaison? Okay, I'm not seeing any, so there, just a second. Yes, go ahead, Dr. Sanchez.
Thank you. Sarah, that was great as always. Thank you. I was just wondering, when you look at the cumulative hospitalizations in adolescents and when you compare it to influenza, does it take into account the screening that is being done in many hospitals and admission for other conditions, or is that, is there any, because, we're screening routinely in many places or on admission to the hospital, at least for COVID-19, and is this, the data that you showed, does it break out the ones that were done for screening or the ones who had disease?
Thanks for that, Dr. Sanchez. We do know that testing patterns, vary. Dr. Havers, if you're able to comment on, how you guys handle potential screening as it relates to COVID-associated hospitalization rates.
Sure. No, thanks for that question. That's a good question. In the comparison with the historical influenza rates, it doesn't take into account differing testing practices. And I think that among all of the children in that analysis had a recent positive SARS-CoV-2 test, but it is possible that a certain proportion could have just been admitted for screening or other reasons. And we also know that influenza is underdiagnosed, and as not all children who are hospitalized are tested. So that could account for some of the discrepancy between the rates. Although others have pointed out in looking at those numbers that the rates of COVID-associated hospitalizations were higher than historical influenza-associated hospitalization rates, despite the fact that we've had a lot of community mitigation measures, school closures, mask wearing, and other things, but definitely differing testing practices and screening could affect those results. Thank you.
Thank you. Are there any other questions before we move on to the next presentation? All right. Thank you very much, Dr. Oliver, and we'll move on to the next presentation, which is by Dr. Woodworth on the clinical considerations for the Pfizer-BioNTech COVID-19 vaccination in adolescents. Dr. Woodworth.
Thank you. Next slide. Interim clinical considerations for COVID-19 vaccines are available on CDC's website and apply to the use of the Pfizer-BioNTech, Moderna, and Johnson & Johnson COVID-19 vaccines under the FDA's Emergency Use Authorization. These clinical considerations are being updated for adolescents and to include recommendations regarding vaccine co-administration and vaccination after multisystem inflammatory syndrome in children, or MIS-C, and adults, or MIS-A. I'll highlight a few here. Next slide. First, administration. Next slide. The Pfizer-BioNTech COVID-19 vaccine is currently the only COVID vaccine authorized by FDA for use under EUA for adolescents aged 12 to 17 years. The dosing and administration schedule is the same as for adults. Next slide. Syncope or fainting may occur in association with any injectable vaccine, especially in adolescents. Procedures should be in place to prevent falling injuries and manage syncopal reactions following COVID-19 vaccination. All people are recommended to be observed following COVID vaccination for at least 15 minutes, and patients should be seated or lying down during the observation period to decrease the risk for injury should they faint. If syncope develops, patients should be observed until their symptoms resolve. Next slide. Next, issues related to consent. Next slide. The federal government does not have specific requirements for medical consent for vaccination, including COVID-19 vaccines. However, states and jurisdictions have medical consent laws that address the circumstances requiring and the processes for obtaining consent. It's important to note that these laws vary across jurisdiction. Providers may also be subject to policy requirements for consent within their own organizations. All sites administering vaccines should follow current state or jurisdictional policies and practices for other routine immunizations in this age group. Next slide. Next slide. So for co-administration of vaccines, due to the novelty of the COVID-19 vaccines, the previous recommendation was to administer COVID-19 vaccines alone with a minimum interval of 14 days before or after administration of any other vaccine to better understand any adverse events. However, substantial data have now been collected regarding the safety of COVID-19 vaccines currently authorized by FDA for use under EUA. Extensive experience with non-COVID-19 vaccines has demonstrated that immunogenicity and adverse event profiles are generally similar when vaccines are administered simultaneously as when they are administered alone. Next slide. For these reasons, the clinical considerations regarding co-administration are being updated to state that COVID-19 and other vaccines may now be administered without regard to timing. This includes simultaneous administration of COVID-19 with other vaccines on the same day, as well as co-administration within 14 days. Next slide. To the question raised earlier about routine adolescent immunizations, we do want to take this time to note that these updated co-administration recommendations may facilitate catch-up vaccination of adolescents. Early in the pandemic, vaccines for children provider orders of routine immunizations fell substantially. While overall VFC provider orders have rebounded from lows seen earlier in the pandemic, there is still a substantial deficit for 2020 and 2021, with overall orders other than influenza down by 1.7 million doses. The largest gaps are seen with vaccines primarily given to adolescents, including Tdap, HPV, and meningococcal conjugate vaccines. Many school-aged children missed recommended vaccines over the last year due to disruptions associated with COVID-19, and schools may not have focused on compliance with school vaccination requirements during the 2020 to 21 school year. The need for catch-up vaccination in coordination with COVID-19 vaccination is urgent as we plan for safe return to in-person school. Next slide. Next slide. So clinical considerations for people with a history of MIS-C or MIS-A. MIS-C and MIS-A are severe hyperinflammatory syndromes occurring 2 to 6 weeks after acute SARS-CoV-2 infection and result in a wide range of manifestations and complications. The mechanisms of MIS-C or MIS-A are not well understood, but include a dysregulated immune response to SARS-CoV-2. Next slide. Children with a history of MIS-C have high antibody titers to SARS-CoV-2. However, it's unknown if this correlates with protection against reinfection and for how long protective antibody levels persist. It's unclear if people with a history of MIS-C or MIS-A are at risk for reoccurrence of the same dysregulated immune response following reinfection with SARS-CoV-2 or in response to a COVID-19 vaccine. Next slide. People with a history of MIS-C or MIS-A may choose to be vaccinated. Considerations for vaccination may include clinical recovery from MIS-C or MIS-A, including return to normal cardiac function, personal risk of severe acute COVID-19, such as age or underlying conditions, level of COVID-19 community transmission and personal risk of reinfection, and lack of safety data of COVID-19 vaccines following these illnesses, and timing of any immunomodulatory therapies. Next slide. Current evidence suggests that the risk of SARS-CoV-2 reinfection is low in the months after initial infection, but may increase with time due to waning immunity. Thus, people with a history of MIS-C or MIS-A should consider delaying vaccination until they have recovered from illness and for 90 days after the date of diagnosis of MIS-C or MIS-A, recognizing that the risk of reinfection and therefore the benefit from vaccination might increase with time following initial infection. Next slide. Finally, healthcare personnel or health departments can request a consultation from the Clinical Immunization Safety Assessment COVID-Vax project if they have complex COVID-19 vaccine safety questions that are not addressed by CDC guidance. Next slide. And finally, I'd like to touch on contraindications and precautions. Next slide. Anaphylactic reactions have rarely been reported following receipt of COVID-19 vaccines, and information is available on the CDC website regarding preparing for the potential management of anaphylaxis at COVID-19 vaccine sites. Next slide. The following are considered to be contraindications to vaccination with COVID-19 vaccines: severe allergic reaction or anaphylaxis after a previous dose or to a component of the COVID-19 vaccine, an immediate allergic reaction of any severity to a previous dose or known diagnosed allergy to a component of the vaccine. Of note, known polysorbate allergy is no longer a contraindication to mRNA vaccines, including Pfizer, but is a contraindication to Janssen COVID-19 vaccine and thus a precaution to the mRNA COVID-19 vaccine. Next slide. CDC recommends that vaccine providers observe all persons after vaccination, those with a precaution to vaccine or a history of immediate allergic reaction to a vaccine or injectable therapy, or contraindication to a different type of COVID-19 vaccine or history of anaphylaxis should be observed for 30 minutes, and all other persons should be observed for at least 15 minutes. Next slide. I'd like to briefly mention some of the resources CDC has developed around COVID-19 vaccines that will be relevant for vaccine providers, parents, and teens. So next slide. CDC has developed additional tools that providers can use at the vaccination site to help identify persons with contraindications or precautions to vaccination, including pre-vaccination checklist. Next slide. There are numerous resources available regarding COVID-19 vaccine administration, storage, reporting, patient education, and more on the CDC's website. Next slide. And then finally, a few discussion points for AAP. Next slide. So the discussion questions are, does ACIP agree with the proposed clinical considerations related to vaccination? And are there any sections of the clinical considerations that ACIP would like to discuss?
Thank you very much for that presentation. We will open that up now. Dr. Freihofer, do you have questions or comments?
I'm not a member of ACIP. I'm a liaison, but I'm happy to ask the question if there are no ACIPers that want to feed me.
There are, but your hand was up first, so we will allow you to go first.
Okay. I have a question about the MIS-C and MIS-A. On one of your slides, you said that MIS-C and MIS-A occur 2 to 6 weeks after acute infection. And then you mentioned waiting for vaccination until the person is recovered or until 90 days after the diagnosis of MIS-C or MIS-A. So this is just a question. In order to make sure someone is not going to have MIS-C or MIS-A, if it usually occurs 2 to 6 weeks after an acute infection, does it make sense to wait at least 6 weeks after COVID infection to consider vaccination?
So that recommendation to delay vaccination was specific to persons who have a history of diagnosed MIS-C or MIS-A. So that waiting period of 90 days was specific for people with a diagnosis. Also just want to note that this is a very rare outcome, so this applies to really a small number of persons in the United States.
Thank you. Dr. Long.
Yes, I guess the question is, do we want to consider or discuss further? I would like to have a further discussion on the relaxation of timing between vaccines. Particularly, I assume, Dr. Woodworth, when you were speaking, we switched from Pfizer to what I think you're talking about, all coronavirus vaccines. And if that's correct, I think we should have a little bit more discussion about mRNA vaccines and other live virus vaccines as concurrent or one following the other. I know that it is not a non-replicating adenovirus, but it uses an adenovirus to get where it needs to be. And I'm thinking of someone who had a live virus vaccine who might have some interferon going, all of that. I think that I would like to have a little discussion sometime about that one. Thank you.
Are there any comments? We'll come back to that then, Dr. Long. Let me go to Dr. Daly.
Yeah, I was hoping to discuss that same question. I mean, Dr. Woodworth, thanks for the presentation, and I'm also concerned about decreased immunization rates for routine vaccines, and also reassured by the fact that the data from the Pfizer-BioNTech vaccine showed it to be highly immunogenic in 12 to 15-year-olds. But honestly, I would have preferred to have more data on immunogenicity and safety when co-administered with other vaccines. So I guess my question is it possible down the road to get more data? And I guess I would ask my FDA colleagues and CDC colleagues whether there's a way to encourage the sponsors to study co-administration for routinely administered adolescent vaccines, for routinely administered vaccines for children, and then also with influenza vaccine. Over.
Dr. Daly, this is Dr. Oliver. We're pursuing multiple avenues for ways to get additional data. We fully agree that having solid data would be helpful, and so we're pursuing multiple avenues for ways to have that information where we can bring it to ACIP.
And from is there a role for the FDA? Sorry, I'm going to jump in. Is there a role for the FDA in terms of, I mean, I'm trying to think of comparisons for the childhood schedule, but is there a role for FDA to say we would like this studied with other routinely administered vaccines to children?
Hi, this is Doran Fink. Thanks for your question. So FDA absolutely encourages vaccine manufacturers to study concomitant administration when concomitant administration would be anticipated to occur in practice with use of the vaccines. These studies to generate data on concomitant administration, both safety and immunogenicity, can become very complex as you add the number of vaccines and the number of antigens being evaluated. And so the added benefit of these data do need to be balanced in some ways with the with the primary goal of generating safety and effectiveness data to support use of the COVID vaccines in certain age groups. So we certainly encourage vaccine manufacturers to study concomitant administration. Our regulatory precedent has not been to require concomitant administration studies as a condition of authorization or licensure. We do certainly encourage them.
Thank you. Thank you for those comments and that information. So let me say that there are a number of ACIP voting members who have their hands up. I'm going to tag them first before we go to the liaison. But prior to that, I understand that Drs. Maldonado and Kimberlin have a statement or joint statement. Dr. Maldonado, Dr. Kimberlin, please go forward.
Yes, thank you, Dr. Romero, and thank you to the members of the ACIP for this moment. I just wanted to state that the American Academy of Pediatrics has put together a policy statement that is embargoed until after the end of this meeting, but it will obviously be read at this point. This is a statement that was put together in consultation with a variety of groups and has received full approval from the American Academy of Pediatrics Board, as well as the Committee on Infectious Diseases. So this policy statement is organizational principles to guide and define the child healthcare system and or improve the health of all children around COVID-19 vaccines in children and adolescents. Vaccines are safe and effective in protecting individuals and populations against infectious diseases. New vaccines are evaluated by a longstanding, rigorous, and transparent process through the U.S. Food and Drug Administration and the Centers for Disease and Control and Prevention, by which safety and efficacy data are reviewed prior to authorization and recommendation. The American Academy of Pediatrics recommends the following related to COVID-19 vaccine in children and adolescents. First, the AAP recommends COVID-19 vaccination for all children and adolescents 12 years of age and older who do not have contraindications using a COVID-19 vaccine authorized for use for their age. Number two, any COVID-19 vaccine authorized through emergency use authorization by the FDA, recommended by the CDC, and appropriate by age and health status can be used for COVID-19 vaccination in children and adolescents. And finally, number three, given the importance of routine vaccination and the need for rapid uptake of COVID-19 vaccines, the AAP supports co-administration of routine childhood and adolescent immunizations with COVID-19 vaccines or vaccination in the days before or after for children and adolescents who are behind on or due for immunizations based on the CDC AAP recommended child and adolescent immunization schedule and or at risk, increased risk from vaccine preventable diseases. So that's the end of the statement, and I will be happy to provide a copy of that to the chair of the committee.
Thank you, Dr. Maldonado. Dr. Kimberlin, just want to make sure that you didn't have another comment to make.
No additional comment from me. I think Bonnie's statement on behalf of the AAP is definitive in terms of the AAP's position on this.
Thank you both for this. So let me turn this back to questions or comments directly related to those offered by Dr. Maldonado. And let me start with Ms. McNally.
Thank you. I have a few short questions. So my first is thinking about parents. Is it fine to give Tylenol, Advil, Motrin, et cetera, post-vaccination?
Yes, if symptoms are present, it's certainly fine to give age-appropriate Tylenol or ibuprofen.
Do we know yet how long this vaccine will be effective in children in preventing coronavirus? And is there any discussion about a booster dose?
This is Dr. Oliver. We're going to continue to follow studies for that, and we'll bring information to ACIP as soon as we have information on either duration of immunity or booster doses.
Thank you. Are the state registries and territorial registries set up to include COVID vaccination information for this age group?
Yeah. Yes. So state immunization registries will be able to capture COVID-19 vaccinations for adolescents and others.
And are our safety systems able to adequately monitor the issue of co-administration?
This is Dr. Oliver. I am pulling up the exact statement. So we're working, parents or guardians can register their adolescents in VSafe and complete the health surveys on their behalf. So there will be information around the use of VSafe in the 12 to 15-year-old populations.
But will the systems that are in place be able to flag any issues if something should arise with co-administration?
Sarah, this is Tom. Do you want me to take that?
Sure.
This is Tom Shimabukuro with the Immunization Safety Office. So in our VAERS reporting, there's the opportunity to include really almost as many vaccines as would be given at any one visit. So there are multiple fields to include multiple types of vaccinations. So what we will be capturing and analyzing reports of COVID given with simultaneous vaccination if there are any reports submitted. Likewise, in our VSD monitoring, we are able to capture co-administration of other vaccines. So we will have visibility on that issue. Over.
Great, thank you, very helpful. And just one more question. So I think that the AAP's position has been very helpful for me in thinking about the co-administration and in particular regarding the fact that, we have to be thinking about catch-up vaccination. So my question is, I know that there's going to be information for pediatricians and other healthcare providers regarding the co-administration issue. Is there something that's also being prepared, or is it already prepared to help educate parents about the issue of co-administration?
This is Dr. Cohn. Yes, we are working on multiple education tools for both, obviously, providers as well as for parents, and we will be including questions about and responses around co-administration and near-time administration, co-administration for parents.
Thank you very much. That's all I have.
Thank you for those questions. Very useful. Let me go to Dr. Sanchez.
Yes, thank you, Dr. Romero. So this co-administration, I have to admit, caught me off guard, and certainly is a frequently asked question in the current group that who are being vaccinated. This doesn't only apply to the 12 to 16-year-old group, but it applies also to pregnant women getting their Tdaps. Applies to I've had questions from homeless shelters who want to get hepatitis A vaccine as well, and of course to adults. So it really has very broad implications. And on the one hand, I'm very supportive because I think it's critical that we vaccinate individuals, including children, at the time that they're there and not waste a single moment to provide the vaccine. But my question, and I guess my concern is, what are the data? Do you have the data, or is it just based on the fact that we have accrued safety with respect to the current vaccines, at least the messenger RNA? And do we, what data do you have available beyond the fact that we now feel very comfortable with the administration of these vaccines? And also, do we have any data with the adenovirus vector vaccines with co-administration, specifically with those, And I don't know if any of those other individuals who had the thromboses and the clots, whether do you have any data co-administration with any other vaccines was given to those patients as well? Thank you.
Thanks so much for that question. So a couple of points to be made there. So one, I just want to clarify that yes, the co-administration would not only apply to adolescents. So thank you for clarifying that. It would apply to all persons currently under the EUA. And also do want to state that, this recommendation originally for the spacing of greater than 14 days was made sort of out of an abundance of caution so that we'd be able to understand and get sort of this clear safety data that we have now been able to collect. And so because of that sort of substantial amount of data that we have now about the vaccines under EUA, we're sort of updating these recommendations to now allow for co-administration. For the specific question about the clots and Janssen, I will turn to Sarah Oliver to answer that. But I will just add also that, we do have, like Dr. Shimabukuro mentioned, the VAERS safety data does collect information on co-administration. So we do already collect some safety data on co-administration already and have some data there. But I'll ask Sarah about, or Dr. Oliver about the Janssen data.
Yeah, and I can say something and then see if Karen Broder has anything to add, but there's no indication, all of these TTS cases have had a medical chart review, and there's not been any indication that there's been co-administration that has contributed to a TTS case. Karen, Dr. Broder, with CISA.
This is Karen Broder. I concur with that based on our available information. Thank you.
I have another question. Will VSafe be able to capture, or would you be able to amend VSafe to see whether there's been administration for any other vaccine?
Hi, this is Tom Shimabukuro. Currently, VSafe focuses on COVID vaccines. We don't have plans to expand to include other vaccines. However, just want to reinforce what I said earlier, that the vaccine adverse event reporting system is our frontline system for monitoring adverse events, especially early on during the initial uptake period for new vaccines or newly recommended vaccines. And there's ample space to record multiple vaccinations on the VAERS form. So if there are any reports of adverse events that include co-administration, if it's documented in the VAERS form, we will capture that information.
And Dr. Sanchez, this is Dr. Cohen. I'll respond to your question. But I just want to add one more, just to clarify. We did do a landscape outreach to multiple different groups to identify if there would be any data available to consider for this meeting. And we did not, there's no data that will be available before the summertime to consider for co-administration. There's a couple of small studies that are starting that we're hoping to have some safety data before influenza season. But given the concerns around childhood and back-to-school vaccination, adolescent and back-to-school vaccination, this language is being proposed in the absence of additional data that specifically looks at co-administration, but simply because of the known safety, because of the safety profile of COVID vaccines, along with the many years of experience with co-administration with inactivated vaccines.
Thank you. Dr. Lee.
Thank you. I wanted to reiterate what Dr. Daly said at the beginning, which is I do feel the need, and I recognize that we're not going to have this data, but the need to really advocate for studies by the manufacturers to really be able to give us better data on immunogenicity and safety of co-administration or administration within 14 days. All of the safety data, which is tremendous, I have to say, we've vaccinated over 150 million individuals, and the safety data is huge. It is primarily in adults. We are about to embark on, a journey with younger and younger kids over time. And kids might be different than adults in their response. In that, I think, we see MIS-C as a consequence of COVID infection in children, which we tend to see much less commonly in adults. So I think we're going to need to just make sure that we are attuned to vaccine safety as we anticipate we will be. But I just want to, mention that that is my, I still have a worry, but I understand that we are not going to have perfect data to be able to move forward, so that the implementation considerations here and also the importance of ensuring kids are fully vaccinated, particularly as we're going back to school, is really important. The other comment I just want to make is that, while I'm not worried about co-administration of most vaccines, to be honest, there are some vaccines where co-administration might have, more anticipated adverse events. And I'm thinking specifically of the recombinant zoster vaccine, in part because we know that at baseline, adults who get that have been surprised by how significant an impact it has in terms of reactogenicity. I'm speaking only of reactogenicity in this moment. But given that both vaccines have significant reactogenicity profiles, I just think it might be at least worth making individuals aware that co-administration in that case might have a greater impact than we would anticipate. And then I just want to clarify, I think it'll be really important for providers and patients to continue to report into theirs and really advocate that mechanism for sharing vaccine safety data going forward. I do think, and I don't know if it's flexible, Dr. Shimabukuro, but I do think that it is same-day administration that it captures. I'm not sure we'll capture information about within a 14-day interval, but I think we could encourage individuals to input that information going forward, because I think it'll be critical for us to be able to review as much data as quickly as possible. Thank you.
Thank you for those comments, Dr. Lee. Let me go back to Dr. Long, and then we'll start with the liaisons. Dr. Long.
I'm with Dr. Sanchez, and this caught me off guard, so I haven't had time to think about it, and my ongoing concerns have not been alleviated in both directions, that concurrent administration might interfere with one or the other vaccines, or might affect reactogenicity or more uncommon adverse events. It's kind of a slam dunk for a new conjugate vaccine, pneumococcal conjugate vaccine 13. You show me one study that there's co-administration with an inactivated influenza vaccine, and it doesn't affect immunogenicity, and it doesn't significantly affect reactogenicity. That's easy. That's easy. These are brand new. We don't have, and we know it's not always simple. We know that a young infant can be overwhelmed with the diphtheria component of a vaccine that can interfere with response to another vaccine. So, potentially you could lose what is miraculous response to pneumococcal and Haemophilus vaccines by something you don't know. So, and it's lack of my understanding exactly how messenger RNAs could interfere or especially interfere with the response to another one. And the adenovirus vaccines, I think there's no question that there is a signature inflammatory response that's different from every other vaccine that we've given. So that I'm not at all comfortable with deciding right now how these vaccines can be used concurrently with anything without any data.
Thank you for your comment. Let's go back to the top of the list. Dr. Schaffner.
Yes, thank you, Dr. Romero. Everything said, co-administration certainly seems to be a major theme in these comments, but the National Foundation for Infectious Diseases certainly welcomes the new recommendations and clinical guidance from the CDC and the AAP regarding co-administration, and would like to emphasize especially that there will be the usual flu vaccination campaigns that go on this fall, and that essentially all adolescents are recommended to receive influenza vaccine. We certainly welcome data on the subject of co-administration as they become available. And while I have your attention, I'll join Dr. Sanchez in noting that this same permissiveness, if we can call it that, for co-administration now extends to adults also. Thank you.
Thank you very much. Dr. Goldman, please.
Thank you, sir. Well, Dr. Sanchez and Dr. Schaffner took some of my comments already, so I'll try and be brief. I'm really concerned how the lack of co-administration has also disrupted the adult vaccination program. And I really think that we need to address this issue and make it very clear that the initial 2-week decision, as was noted, was more for an abundance of caution as opposed to any overwhelming safety concerns. And the reason why this needs to be really fleshed out is because many vaccination sites adhere so strictly to the guidelines without understanding the reasoning behind it, to the point that they don't change quickly to changes in the recommendation and maybe limiting the ability for people to get necessary vaccines, number one. Number two, patients are very concerned and may not understand or appreciate why there was a change unless it's really explained to them that it wasn't for any safety concern, but an abundance of caution. And number three, as noted, it has disrupted the adult vaccination program, and we have tremendous safety data on other vaccines and co-administration. And referencing something you said, Dr. Romero, at a previous meeting, paraphrasing, that we may not always have all the data and evidence, but we do have experience and expert opinion. And while we may not have all the data to fully answer the question of co-administration regarding this, we do know how the science works, we do know how mRNA technology works, and we do know how other vaccines work. So I'm comfortable with co-administration, certainly in the adult population. If there is a concern between pediatrics and adults, if the committee sees fit to perhaps separate that discussion, because I really do feel we should be able to co-administer with adults and be able to get them back on their adult vaccination pathway as well as for pediatrics. But if it is an overwhelming concern for the pediatric population, then certainly maybe separating that question may be appropriate. Thank you.
Thank you for those comments. Let me make an editorial comment here very quickly. We are coming up on the top of the hour, which will be the beginning of our public comment session. There are a number of individuals that want to speak. I've written their names all down. We will take the public comment session, and I promise you that I will call on you in the order that you are listed at this time, and add anyone else who needs to make comment. We're not cutting this short. So let me go to Dr. Freihofer. Maybe not. Let me come back to that. Dr. Dries?
I'm sorry. Can you hear me now?
Yes, again.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. Many kudos to CDC's proposed guidance on co-administration, and I'm very reassured by the AAP statement of support. Now, I realize that today was all about teens, but I was very excited that it was confirmed that this co-administration also applies to adults. But I echo Dr. Lee's concerns about co-administration of vaccines that have adjuvants, aka the shingles vaccine, the flu-ed vaccine, with the COVID vaccines. I mean, I'm concerned about a double whammy of reactogenic side effects. And right now, patients have many options as to where to get their vaccinations, but I'm the one that gets all the phone calls when they have side effects. So if ACIP has any specific guidance about anything particularly different to do with these adjuvanted vaccines, as a practicing physician, I and my patients would welcome that guidance.
Dr. Romero.
Thank you very much, Elizabeth.
Dr. Romero, this is Dr. Cohn. I want to interrupt and just say that it would be good if we could take about a 5-minute break, but I also, 2 quick comments. One is just, I want to make it clear that there is no contraindication or precaution against co-administration in the FDA emergency use authorizations for any of the COVID vaccines. And secondly, we have listened to these comments so far, and I think what we can do is we can add some caveated language after the co-administration sentence to sort of remind people that there may be some vaccines where there may be additional side effects that may be compounded. A reactogenicity, and then we can come back after the next break to show that revised language as you're taking the rest of the comments. And then finally, I'll just remind everyone that this is clinical considerations guidance, which is great because we can change it when we want to, and frequently. But also, I think that this will not. Sorry, just to clarify, this is not language that will be voted on by ACIP today.
Thank you, Dr. Cohen. Let's do the following then. We have 5 minutes before the public comment session. Why don't we take a 5-minute break, come back to the public comment session. I have the names recorded, and we'll call on you after the break following the public comment. So 5 minutes, please. Thank you very much.